মিনিটের মতো আর কি।
তারপরে হচ্ছে আমি 30 সেকেন্ড সময় নিব, সময় নেওয়ার পরে তারপরে আমরা চলে যাব, মানে আমরা চেষ্টা করবো 9:30টার মধ্যে শুরু করতে। হ্যাঁ
ঠিক আছে স্যার। স্যার আপনার তো গলা কেটে যাচ্ছে স্যার, একটু যদি উঁচু হয়ে বসতেন বা ওইটা ভালো ছিল।
ও আচ্ছা, গলা কেটে যাচ্ছে, সে হচ্ছে আমাদের ব্যানার নিতে গিয়ে আমার গলা কেটে গেছে, কি করবো।
স্যার আপনি চেয়ারটা একটু উঁচু করে বসলে স্যার ঠিক ছিল, চেয়ারটা যদি একটু উঁচু করে বসতেন।
একটু স্যার, এটা কি হবে, পিছায় বসবো?
পিছিয়ে বসতেন। এখন স্যার আগের মতো রাখেন। হ্যাঁ ঠিক আছে, এই একদম ঠিক আছে স্যার।
এবার বেটার, ঠিক আছে হইছে। আমার মাথা থেকে তো আমাদের কনফারেন্সের কথা মোর ইম্পর্টেন্ট, ওটা দেখলেই হবে। মানে
ঠিক আছে মারুফ।
হ্যাঁ আপা, থ্যাংক ইউ থ্যাংক ইউ।
তোরা স্যারকে কেউ লাগাই দিতে পারলো না এটা, ফারজানা কাউকে পাঠাতে পারলো না, এটা একটা কথা।
পাঠিয়েছি আমরা স্যারকে, আর তো নিজে ব্র্যান্ডিং, আর স্যার কি পাঠাবো। হ্যাঁ আপা, আসসালামু আলাইকুম।
এই ব্যাকগ্রাউন্ড গুলা মাঝে মাঝে ভালোই লাগে, খারাপ লাগে না।
আসসালামু আলাইকুম স্যার, আসসালামু আলাইকুম ম্যাডাম, আসসালামু আলাইকুম ভাইয়া।
ওয়ালাইকুম আসসালাম। ফিরোজা আপা আসসালামু আলাইকুম, আনমিউট হন।
হ্যাঁ হয়েছে। আসসালামু
তুমি
আলাইকুম
আনমিউট হয়ে একটু চেক করে নাও।
স্যার। আসসালামু আলাইকুম।
ওয়ালাইকুম আসসালাম।
আসসালামু আলাইকুম ভাইয়া, আমি অডিবল?
হ্যাঁ অডিবল।
থ্যাংক ইউ ম্যাডাম। ম্যাডাম আসসালামু আলাইকুম।
ওয়ালাইকুম আসসালাম।
ম্যাডাম আসসালামু আলাইকুম। ম্যাডাম আপনার ওই ল্যাপটপের ইয়েটা যদি একটু উঁচুতে তুলতেন, আপনার মাথাটা কেটে যাচ্ছে।
তার মাথা কেটে যাচ্ছে।
ম্যাডাম মাথা কেটে যাচ্ছে, হ্যাঁ এই পারফেক্ট ম্যাডাম।
মাথা দিয়ে আর কি হবে, বডি থাকবে না, মাথা। সাড়ে 9টা বাজে নাই, লোকজন আসে নাই।
এই আছে এখন 10 মিনিট আছে এখনো।
সেই
লাস্ট মোমেন্টে জয়েন করবে।
হ্যাঁ না জয়েন
18, আমার ল্যাপটপে দেখি 9:18 দেওয়া টাইম।
হ্যাঁ না বলছি যে জয়েন করবে না সেটা না, জয়েন করবে
না, বললাম লাস্ট মোমেন্টে জয়েন করবে কিছু।
সবাই লাস্ট মিনিটে জয়েন করে।
স্যার আসসালামু আলাইকুম স্যার, আসলে জুমে কিন্তু অত বেশি পার্টিসিপেন্ট হবেন না, কারণ আমরা তো প্ল্যাটফর্মের লিংক দিয়েছি সবাইকে জেনারেল পার্টিসিপেন্টের জন্য। তো আপনারা যারা ম্যাডাম স্যার বিভিন্ন সেশনে প্যানেলিস্ট বা স্পিকার আছেন তারাই কিন্তু জুমে জয়েন করবেন।
ও রিসার্চ পারসন।
আমরা জানবো কি করে যে কয়জন জয়েন করলো তোমার প্ল্যাটফর্মে?
আমরা আজকে দুপুরের দিকে আপনাদেরকে একটা কাউন্ট জানিয়ে দিব, মানে আমরা ব্যাক এন্ডে চেক করে আবার রাতে জানাবো দিন শেষে। ওইটা ম্যাডাম
শোনো, এই প্ল্যাটফর্মের একটা সমস্যা আছে স্যার। আমার যে গত কোভিড এর মধ্যে আমার যত লেকচার সব এই ইনসাইড গ্রুপ থেকে এভরিথিং হ্যাজ বিন কপিড এবং সেটা দিয়ে একটা বই বানায় ফেলছে স্যার। তো একটা ভালো মানে প্রায় কত 450 না 650 পাতার বই, আপনি চিন্তা করেন 21টা লেকচার আছে, সমস্ত স্লাইড, একটা স্লাইডও বাদ নাই। আমি শুনলাম, আমি শুনে আমি বললাম যে আমার তো দেখার ইচ্ছা, তাহলে একটা বই কিনি। 450 টাকা করে বইটা বিক্রি হচ্ছে আজ সুপার মার্কেটে। এই হলো আমাদের
ভালো।
হ্যাঁ না, খারাপ বলছি না।
তোমার লেকচার ব্ল্যাক মার্কেটিং হচ্ছে, এটা তো খুশির খবর।
না স্যার, আমি খারাপ বলি না, আমি এটা কিনে একটা রাখছি, যে আমি তো দেখি না, জানিও না, শুনলাম যখন একটা বই কিনি 450 করে বিক্রি হয়।
আরে নীল খেতে গিয়ে বলবে আমাকে 50% টাকা দিবে, copyright দিবে।
কপিরাইট, হ্যাঁ।
এটা জানি
তাহলে
না।
স্যার মানুষ বই বিক্রি করে কিভাবে তাহলে? আপারটা আপা জানেই না, এটা পুরা চললো
না না,
তাহলে
এটা
তো
তো এটা তো পাইরেটেড।
হ্যাঁ, পাইরেট, রাইট।
ওরা গিয়ে একটা বই কিনে ওদেরকে দিয়ে আসে যে এটা ফটোকপি করো, ওরা করে। কত বাইরের বই এখানে বিক্রি হচ্ছে না,
জি স্যার।
হ্যাঁ,
সব ফটোকপি।
সেদিন আমি আসল সময় আছে স্যার, একটা গল্প করি। সেদিন লিজা বলল ওর মেয়ে হলো লতে পড়ে ঢাকা ইউনিভার্সিটিতে, তো ওখানে ইউকে থেকে একজন মানে ইয়ে দিতে আসছে, একজন এক্সপার্ট আসছে, লেকচার দিছে। তো স্টুডেন্টরা বলছে যে স্যার আপনার বই আমরা পড়ি। তখন উনি একটু অবাক হলো, কই বই দেখি। তো ওরা একটা বই নিয়েও আসলো, দ্যাট ওয়াজ এ ফটোকপি বই, ওনার অরিজিনাল বইটা ফটোকপি করছে। তখন ওরা তো ওর সাথে যারা ছিলেন মানে বাংলাদেশের যারা ভালো যারা ছিলেন, তারা ইউনিভার্সিটি টিচার, তারা তো একেবারে লজ্জায় মরে যাচ্ছে, যেটা পাইরেটেড হচ্ছে ওনার বইটা, এটা আবার ওনাকে এসে বললো কেন। তখন উনি বলল যে ও আচ্ছা ঠিক আছে, তাহলে তোমরা কত দিয়ে কেনো এটা? বলে 200 টাকা। তো বলে যে ঠিক আছে, আমি যাওয়ার সময় আমাকে তোমরা 10-12টা বই দিয়ে দিও, আমি নিয়ে যাব ইউকেতে। তখন ওরা সবাই তো আরো ভয় পাচ্ছে যে উনি এটা কি বলছে। বলে যে না, এটা তো ভালো জিনিস, তোমরা আমার বই পড়তেছো কম পয়সায়, আমার স্টুডেন্টদেরকে আমি এই 10টা বই দিয়ে দিব, তারা তো 200 পাউন্ডে বিক্রি হয়, তারা যাতে এটা পড়তে পারে।
200 পাউন্ড আর 200 টাকা।
হ্যাঁ,
তবে সব চুরির চেয়ে এটা হলো ভালো চুরি,
জি স্যার,
তাই না?
জি স্যার।
কপিরাইট তো অনেক কিছুই করে, ডিজাইন কপি রাইট চুরি করে, কনস্ট্রাকশন, ইনস্ট্রুমেন্ট, সবকিছুই করে, কিন্তু ওইগুলি প্রফিটের জন্য। এতে খুব একটা প্রফিট যে হয় তা না, কিন্তু মোটামুটি ডিসেমিনেশন অফ নলেজ।
তার মোরাল, এখানে একটা মোরাল আর এথিক্স এর ব্যাপার আছে।
হ্যাঁ, মোরাল এথিক্সের ব্যাপার তো অবশ্যই আছে, এটা তো কোনো অবস্থাতেই অ্যাপ্রুভ করা যায় না।
জি স্যার।
তবে ওই এটা একটা ট্র্যাডিশনের মতো হয়ে গেছে গরিব দেশের জন্য। এমনি তোমার ইউএসএ ইউকেতে কেউ এই কারবার করবে না, কারণ আর্থিক দিকটাও চিন্তা করতে হয়, যে হয়তো অনেক ছেলেপেলে বই পায় না। তবু আমরা এটা কোনো সময় অ্যাপ্রুভ করব না, তবে নেসেসিটির জন্য হয়তো কোনো সময় করে।
না, আমার স্যার ফিটোমেটানাল মেডিসিনে আমি একটা কনফারেন্সে গেছিলাম, তো ওইখান থেকে ওদের জন্য টেক্সট বই কিনে আনছি, যে টেক্সট বই তো বাংলাদেশে নাই। তো আমি ওখানে কনফারেন্স থেকে সবচেয়ে ভালো যে টেক্সটটা আমি কিনে নিয়ে এসেছি, সেটা বোধহয় আমার 12 থেকে 15,000 টাকা লাগছে। তো আমি এনে তখন যারা স্টুডেন্টরা ঢুকছে ওদেরকে আমি দিলাম যে তোমরা এইটা পড়ো। তো ওরা ওখান থেকে কেমন করে স্ক্র্যাচ করে ওই যে একটা ইয়ে থাকে, নাম্বার থাকে, ওইটা দিয়ে ওরা বই বের করে বই ফটোকপি করে ফেলছে। এখন রিসেন্ট যে বইগুলো কেউ আর কিনতেছে না, অরিজিনাল বই আমি তো না হয় একটা কিনছি, কেউ আর রিসেন্ট কিনতেছে না। আজিজ মার্কেটে গেলে আপনার রিসেন্ট যে এডিশন বের হয়েছে সেটার ফটোকপি পাওয়া যায়, সবাই এখন ওই রিসেন্ট এডিশন গুলোর ফটোকপি কিনতেছে ওখান থেকে অনেক কম পয়সা।
আর কিছু কিছু অথর আছে, তারা গ্রেসিয়াসলি তাদের কপিরাইটটা দিয়ে দেয় ডেভেলপিং কান্ট্রির জন্য, যাতে কম পয়সায় প্রিন্ট করা যায়। তার সেটাও করে অনেকে, সেটা তাদের বদান্যতা, কিন্তু চুরি করাটা উচিত না কোনো অবস্থাতেই।
থাক, কিছু হবে না, করুক, পড়বে তো, আর তো কিছু করবে না।
ওই আর কি,
আসলে
ভালো কাজের জন্য চুরি করছে।
হ্যাঁ, করুক।
তবে বই লিখে বড় লোক হয়েছে এরকম কোনো উদাহরণ খুব একটা নাই।
না স্যার, বইতে তো পয়সা দেয় না।
হ্যাঁ, ওটাই পাবলিশারই নিয়ে নেয়। ধরো হুমায়ুন আহমদের মতো বই হলে পয়সা দিত কিছু, কারণ ওটা না দিলে তাদের চলবে না, কিন্তু অন্য প্রমিস করে কিন্তু কিছুই দেয় না প্র্যাকটিক্যালি। কিন্তু আমি
দিবে কারা? ক্রেতারা কিনবে, তারপরে তো কাস্টমাররা কিনবে, তারপরে
চিন্তা করি যে ধরো বই মেলাটা
স্যার আমার বইটা আমি এখনো তো পাবলিশার কাউকে দেই নাই, কিন্তু কয়েকজনের সাথে কথা বলছি বাইরের পাবলিশার, তারা হচ্ছে একটা পয়সাও দিবে না স্যার, একটা পয়সাও দিবে না, উল্টা বই কেনাবে, 1 থেকে 1,500 কপি কেনাবে যে তুমি বিক্রি করো।
হ্যাঁ, এখন এরকমই হচ্ছে, কারণ ওরা প্রফিটেবল। আজকাল অনেক জার্নালেও আর্টিকেল পাবলিশ করতে হলে, বিশেষ করে তুমি যদি কালার্ড ফটো দিতে চাও, তাহলে তোমাকে পয়সা দিতে হবে।
ওই যে চিন্তা করেন আপনি, তাহলে করে লাভ কি এত কষ্ট করে?
এটা তোমার নিজের সুনামের জন্য, কিন্তু
আসসালামু
সেটা
আলাইকুম।
অন্যভাবে নিচ্ছে আর কি।
আপা আসসালামু আলাইকুম।
জয়েন করছে, দেখতে পাচ্ছি না।
আনোয়ারা আপা।
ও আচ্ছা, দেখি সবার চেহারা। কই আপাকে তো দেখছি না আমি।
আপনার স্ক্রিনে না, আপনি স্ক্রিনে দেখেন, স্ক্রল করলে দেখতে পাবেন। একটাই তো স্ক্রিন। হ্যাঁ,
দেখতে চাচ্ছি। আসসালামু আলাইকুম আপা।
আপা আনমিউট হন।
আনমিউট করে নেন।
করছে আনমিউট। আপা আসসালামু আলাইকুম, শোনা যাচ্ছে? শোনা যাচ্ছে? উনি আনমিউট হন নাই।
আনমিউট হন, একবার টিপেন, একবার।
অনি, দিবাকে ফোন করো, তোমার অ্যাপোর্টারকে ফোন করো, মডারেটরকে ফোন করো।
আপা এখনো মিউট হয়ে আছে। ইফাত জয়েন করছে।
আনোয়ারা ম্যাডাম, আসসালামু আলাইকুম। ম্যাডাম একটু আনমিউট হয়ে নেন, আপনি মিউট আছেন, একটু আনমিউট করে নেন।
ঠিক আছে, এখন শোনা যাচ্ছে?
হ্যাঁ ম্যাডাম, ঠিক আছে।
দেখতেও পাচ্ছি, শুনতেও পাচ্ছি।
ফিরোজাকে অনেকদিন পরে দেখলাম।
হ্যাঁ আপা, হাইবারনেশনে চলে গেছিলাম।
সেটাই তো, এখন তো সুস্থ লাগছে একদম। কে জানি বলে তুমি অসুস্থ।
অসুস্থ থাকা ভালো মাঝে মাঝে, তো কাজও করা যায়।
আপা জয়েন করছেন এখন।
ম্যাডাম আসসালামু আলাইকুম, একটু নিচে তাকাতে হবে ম্যাডাম।
হ্যাঁ হ্যাঁ, সেটাই আমি ওটা জিজ্ঞেস করতেছিলাম, ক্যামেরাটার দিকে তাকাইতে হবে। হ্যাঁ ঠিক আছে, ওকে।
ইফাত আপা কি মোবাইলে নাকি?
না না, মোবাইলে না, ল্যাপটপে।
ও তাহলে সামনে তাকান।
হ্যাঁ সামনে না, নিচেই আছে, ক্যামেরাটা নিচে, ক্যামেরা নিচে।
ম্যাডাম আসসালামু আলাইকুম।
বুঝছো ইফাত?
হ্যাঁ ওয়ালাইকুম সালাম।
তাকায় কথা বলছো।
আনমিউট করছো তুমি? হ্যাঁ নিজেকে আনমিউট করছি তো, আনমিউট হয়ে গেছে। আমি আসসালামু
হ্যাঁ
আলাইকুম।
শোনা যাচ্ছে তো। হ্যাঁ ওয়ালাইকুম আসসালাম, ইফাতকে শোনা যাচ্ছে তো।
আমি
আর ক্যামেরাটা একটু নামালে ভালো হতো।
আসসালামু আলাইকুম স্যার।
হ্যাঁ,
যা
ওয়ালাইকুম।
হয়ে আছে।
ইফাত আপার লুকটা কেমন জানি অন্যদিকে তাকায় আছে।
উপরের দিকে, উপরের দিকে, সেটাকে ঠিক করতে হবে। কিভাবে ঠিক
না না,
করব?
আমি নিচের দিকে তাকাচ্ছি, আমি ঠিক করে দেবো। আমার মনে হচ্ছে উপরের দিকে হচ্ছে।
ম্যাডাম
হ্যাঁ।
একটু পেছনে যান, অথবা ল্যাপটপটাকে আর একটু পেছনে দেন, দিয়ে একটু নিচের দিকে তাকান। হ্যাঁ, ল্যাপটপটা যদি ইউজ করে থাকেন একটু সোজা করে নেন,
আচ্ছা
বেশি টিল্টেড হয়ে গেছে।
এখন ঠিক হয়ে গেছে।
আর একটু সামনে আনেন ম্যাডাম স্ক্রিনটা। হ্যাঁ এটা বেটার। এখন ম্যাডাম একটু ইয়েটা, ল্যাপটপের ক্যামেরাটা একটু নিচের দিকে ম্যাডাম।
ক্যামেরাটা নিচের দিকে, হ্যাঁ।
হ্যাঁ ক্যামেরাটা নিচের দিকে। এবার বেটার, মাচ বেটার ম্যাডাম।
পারভিন, আসসালামু আলাইকুম।
ওই
শোনা যাচ্ছে না?
এটাকে সরাই দাও, এটা তো আমি চাই না।
ঠিক আছে,
তারপরে
সাউন্ডটাও বাড়াই দাও। যখন তুমি তোমার
আসসালামু আলাইকুম পারভিন আপা।
ওয়ালাইকুম সালাম
শাহানা।
সবাইকে।
শাহানা আমি।
সবাই হ্যাঁ স্যার
বাবা।
মারুফ,
তারপর-
তোমার ব্যাকগ্রাউন্ড অন্য কেন?
মারুফ
আমি জানতাম আপনি প্রথমেই প্রশ্ন করবেন।
দাঁড়াও, তোমার মানে চিন্তা
এবার
করো।
আমি ভাবলাম মারুফ স্পেশাল থাকতে চায়, মারুফ এক্সক্লুসিভ থাকতে চায়,
না 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 না
স্পেশাল থাকতে
আপা,
চায়, তাই আমি কিছু বলি নাই এতক্ষণ।
বাকি আছে।
2 দিন 9 ঘন্টা 18 ঘন্টা বসে থাকলে মরেই যাবো।
হয়েছে।
রং চঙা লাগাইছি আর কি, যাতে বেঁচে
হ্যাঁ।
থাকি।
সুন্দর হয়েছে আসলে স্ক্রিন,
That was the proper screen.
কিন্তু এটা সবাইকে দেওয়া উচিত ছিল। পারবেন কি বলছে?
তো সুবিনিয়ারের ব্যাকগ্রাউন্ড দিয়েছে।
হ্যাঁ স্যার,
সুভেনিয়ারটা স্যার।
হ্যাঁ সুবিনিয়ারের ব্যাকগ্রাউন্ডটা এটাই সুন্দর। এনিওয়ে,
9:30 বেজে গেছে, শুরু করবো আমরা?
হ্যাঁ, শুরু করে দাও।
সবাই চলে আসছে ফার্স্ট সেশনে স্যার। ফারজানা ভিডিওটা শুরু করো।
আচ্ছা স্যার, করে দিচ্ছি।
আর স্পিকার যখন হবে, স্পিকার ছাড়া বাকিদেরকে মিউট করে দিও, হ্যাঁ, যাতে বাইরের সাউন্ড না আসে।
আমার সাউন্ডটা দিয়ে দিন।
Assalamu alaikum and good morning. I am Professor Maruf Siddiqui, Joint Secretary FSSB, welcoming you all in this 6th Virtual International Scientific Conference organized by Fertility and Sterility Society of Bangladesh. We had our last in-person conference in 2019, and this is our first virtual experience. This time we have 2,200 registered delegates for the conference, and 19 international faculties and a lot of national faculties attending this conference. Though it's a virtual conference, but sometimes even a virtual conference is expensive, so we would like to expand our heartfelt thanks to Novista Pharmaceuticals, the main sponsor for sponsoring this event. Our heartfelt thanks goes to Renata Limited, Popular Pharmaceuticals, Incepta Pharmaceuticals, ACI Limited, and Healthcare Pharmaceuticals for being our co-sponsor. So we will start our day one procedure. I would like to request our President, Fertility and Sterility Society of Bangladesh, Professor T.A. Choudhury sir, for giving the inauguration speech. Sir is the father figure of gynecology in this country and the teacher of teachers, so I don't think he needs any more introduction. May I request Professor T.A. Choudhury sir to please give his introductory remarks and open the conference. Sir.
Thank you, Dr. Maruf. Dear colleagues, first of all, I would like to welcome you all to this 6th International Conference of FSSB, which is being held virtually. As you all know, that we have passed through a very difficult time and the future was somewhat uncertain. So we had to organize our meeting, or decided to organize our meeting on a virtual platform. So it is a trimmed version. If we were able to organize the meeting face-to-face, possibly many more things could have been added. For example, in this conference, you will not find any dinner, any cultural function, or other associated things that happen in such a big conference. But we are lucky in a way that even there has been no trimming of scientific part of the conference. As a matter of fact, I think we have been in a better position because of this restriction of travel, we have been able to get many eminent personalities in the field of human reproduction and fertility and infertility treatment. As Professor Maruf has said, we have got 19 foreign faculties cramped within these 2 days. And I think all of us will be benefited from their deliberation. I must thank them all for agreeing to take part in this conference. So without going any further, I think we should try to start our sessions regularly in time. And my only request is that we should try to keep our time as correctly as possible. So I think this is all. Please attend these meetings and learn from the experienced speakers who have kindly agreed to talk in this conference. So thank you very much.
Thank you so much, sir, for your introductory remarks. So we will go straight into the conference. May I request Dr. Ani Farjana Rashid, the rapporteur of the first session, to please resume the session. Dr. Ani.
Thank you, Dr. Maruf Siddiqui, Honorable Chairperson, eminent speaker, respected delegates from home and abroad. I am Dr. Farzana Rashid, currently working as an associate consultant of Square Fertility Center. I'm honored today to welcome you all on the first session of the 6th International Conference of FSSB Bangladesh. For many women, the path of parenthood is not straightforward, starting from the unexplained infertility to the tough journey of the ART. This session will cover all the aspects elaborately. This session will be chaired by our honorable chairpersons, Professor Anwara Begum Madam, who is an eminent fistula surgeon, past President OGSB, President Suffolk Bangladesh chapter, and Madam had her colorful journey as an HOD of Obs-Gynae Department of Dhaka Medical College Hospital. Again, we have Professor Ifatara Madam amongst us. Madam is Professor of Department of OB-Gynae of Popular Medical College Hospital, and also Madam was the former professor of the same department of Dhaka Medical College Hospital. Now, I would like to invite Dr. Farzana Diba as the moderator of this session and to continue the rest of the session. Dr. Farzana Diba is currently working as an associate professor of reproductive endocrine and infertility department of Bangabandhu Sheikh Mujib Medical University. Over to you, Dr. Farzana Diba.
Assalamu alaikum. It is my pleasure to welcome you all in this first session of Fertility Sterility Society. It is my pleasure and honor to introduce Professor T.A. Chaudhary sir, who is our mentor, our teacher, our guardian. May I
Ani, possibly Diba is a little bit disconnected. You can continue.
Today we have two of our eminent speakers, Professor T. Chaudhary sir. Definitely sir is not a person who can be introduced by me, but as I want to say, sir is the current president of SSB, professor of Department of Obs-Gynae of Bardim and former President OGSB. And we have our second speaker among us with Professor Parveen Fatima Madam. Madam is the Secretary General of FSSB and former chairperson and professor of Infertility Unit of Bangabandhu Sheikh Mujib Medical University. Now I would like to request Professor T. Choudhury sir to have his speech. Sir, over to you.
Okay. Let me see if I can. So, thank you very much for that generous introduction. Today I'm going to talk about unexplained infertility. And as far as possible, I have tried to make it evidence-based because these patients are actually treated quite haphazardly. So the first is the definition. Why it is not moving? Why it is not moving?
Slide shote den sir ei nicher jagataতে
না স্লাইড শোতে তো দিলাম আচ্ছা
না না ইয়েতে দেন ওটা ফুল স্ক্রিন দেন
স্লাইড শোর সাইনটাতে দেন
ফুল স্ক্রিনটা দেন
ফুল স্ক্রিন তো আর এখানে আসছে না
নিচে নিচে নিচে
নিচের এখানে স্যার
নিচে দেখেন কাপের মতন একটা আছে হ্যাঁ আর একটু নিচে চলে আসেন নিচে আসেন
ওই চারটা ডটের নিচে পাশেরটা
হ্যাঁ আর একটু ডানে যান নিচে
লাল লাল লাইনের মধ্যে স্যার
ডানে
স্যার
লাল লাইনের মধ্যে এখানে এটা
না স্যার এই যে চারটা ডট তার পাশে একটা কাপ সেই কাপটা
আর একটু ডানে আসেন
স্যার না এই যে স্যার এই চারটা ডটের পাশে না আমরা করতে গেলেও আমাদেরটা এরকমই হবে
তিনটা ডট দেখছি আমি
আচ্ছা স্যার এখানে
আচ্ছা ঠিক আছে আচ্ছা আমি
কাপ আছে স্যার একটা বাটির মতো ছবি আছে স্যার
দেখছি না এখানে
এই যে হয়ে গেছিল চলে আসছিলেন
নিচে নিচে
আরেকটু নিচে স্যার
ডানে চলে
ডাইনে
আমাদের স্যার বোধহয় দেখতে পাচ্ছেন না ছোট তো
হ্যাঁ এত হালকা
আচ্ছা থাক আমার মনে
ঠিক আছে
আর আপনি আমার মনে কন্টিনিউ করেন
লাল বর্ডারে স্যার
without wasting any time, let us proceed. I think it will not be a big problem. Now, unexplained infertility, what do we mean by unexplained infertility? So, by definition, this is inability of a couple to achieve a pregnancy in the absence of a definable cause. Currently, there is actually no definite definition by which we can diagnose unexplained infertility. And as you all know, this is a diagnosis by a process of exclusion. So the more thorough you are in your investigation, the lesser number of patients or couples will be diagnosed as unexplained infertility in your practice. Some authors actually believe that unexplained infertility is a non-diagnosis because every couple who is unable to conceive, there must be a cause in the background. This situation is unexplained because in our present state of knowledge, we are actually not able to find out what is the cause. And as soon as we can do that, possibly our diagnosis would change from unexplained to a diagnosis of actual cause of infertility. Problem হয়ে যাচ্ছে। Now, epidemiology. So is it very common? So different references has said that it ranges from 8 to 37%. Now, as you know that the range is very wide. Why that is so? This is because the different centers have got different criteria for the establishment of the cause of infertility. So naturally, depending on their laboratory facilities and their interpretation of the result, the incidence will vary, whether they find a cause or they do not find a cause. Though with more thorough and more expensive investigation, we can find out the cause in some more cases. But generally, it is advised that it is not really worthwhile because finding out a subtle cause does not increase the possibility of better treatment. So we are happy as we are currently. উঠবে কি করে আমি তো বুঝছি না। এটা তো যাচ্ছে না। এইটা আচ্ছা। ম্যাগনিটিউড তো আমি বলেছি যে depending on the criteria used, the reported prevalence of unexplained infertility varies widely. Now, some people say that after 1 year of unprotected intercourse, and also about 30% of the couple presenting with infertility will be diagnosed as a case of unexplained infertility because you will not find any definite cause. So most people believe that they are a subset of population who have got a lower fertility potential. So why some people fail to conceive? Now there are various causes have been cited, and these are actually somewhat not, I can say somewhat vague, because the terms they say that there are problems in which places. So some people have reported some defect in follicular development, some sperm concentration, others have shown reduced fertilization and embryo cleavage, or others have shown defective endometrial receptivity. But we actually do not know which one is actually the cause, or it may be a combination of causes. So when we'll diagnose a couple as having unexplained infertility, so there must be some basic evaluation. And only when this basic evaluation does not reveal any cause, we will diagnose it temporarily as a case of unexplained infertility. So the basic evaluation should provide evidence of ovulation. You can do it whatever treatment you want to do, but there must be proof that the patient is having ovulation. And of this, we think that 3 are important. This is one is the urinary LH surge. Second is the mid-luteal progesterone. Third is serial transvaginal sonography. Adequate sperm production, there must be proof. And that should meet the latest WHO guidelines. You must have patency of the fallopian tubes tested either by hysterosalpingography, sonohysterography, or laparoscopy. Many centers now also include 2 other things in order to exclude unexplained infertility, that is the anatomy of the uterus, which you can do very well by a very good ultrasonography, particularly 3-dimensional ultrasonography. And lastly is the assessment of the ovarian reserve. Though not 100% accurate, it can give you some idea about the fertility status. So these basic evaluation must be done in all cases, and if you do not find any cause, only then you can dedicate that couple as a case of unexplained infertility. So treatment, what are the treatment options? So in such cases, one is expectant treatment. The second, we can say non-pharmacological treatment. lifestyle modification, tubal flushing, fallopian tube sperm perfusion. The third is pharmacological, ovulation-inducing drugs. That means clomiphene, letrozole, and gonadotropin. And third, last is procedural, intrauterine insemination, IVF ICSI, and laparoscopy. Last one is still a little bit controversial. But so in what do you mean by expected treatment? That means we only reassured the couple. And a high spontaneous pregnancy rate has been observed in women with unexplained infertility if you just give them an opportunity to try for a longer period. In one study, the average cycle fecundity was less than normal, but it was still quite significant. So cumulative pregnancy rate is significant even if you do anything. You ask the patient, reassure the patient, and ask them to wait for a little longer. Various other reports have quoted pregnancy rates varying from one, as you have seen the rates. So one recent study has shown that simple expectant treatment, though much does not cost anything, generally gives much better result, not much better, equivalent result compared to other drug-induced treatments. So RCOG suggested that all couples with unexplained infertility should have a period of expectant treatment before going for any assisted reproductive technique. So chances of success in expectant treatment, you do not go it for every couple. The success depends on age of the female partner, the duration of infertility, and the history of previous pregnancy within the same marital relationship. So these are the things that has to be considered. Age less, success more. Duration of infertility less, success more. And previous history of successful pregnancy or even an unsuccessful pregnancy actually increases the chances of expectant management. So expectant management in low resource countries is a feasible alternative to going for aggressive treatment. So expectant treatment may play an important part in the management of unexplained infertility in poor resource setting. Sometimes in one study in a primary care setting, it has been shown that 1 year's expected treatment actually gave a pregnancy rate of 27.4%. Another in a secondary setting gave a pregnancy rate of about 14%. So you can see that these are not insignificant findings. So it is not always necessary to rush to therapeutic measures in all infertile couple patients, that just depending on the situation, give them a chance for expectant treatment. And many of them will be able to become pregnant without any further pharmacological or other type of intervention. So expected in Bhattacharya, he said that the result of expected treatment was the same as giving clomiphene citrate to these patients with unexplained infertility. But he said that in women aged over 37 years, there is a pregnancy rate of only about 1% in a patient who has unexplained infertility. So these are not the cases for expectant treatment. So expectant treatment should be given in women who are younger, because after the age of 37 years, the ovarian oocyte pool declines rapidly. And at that time, just asking the patient to have expectant treatment means wasting valuable time. So no treatment is absolute. You have to consider that according to the patient's circumstances. So patient condition approaches, what you can advise to the patient during this period. Cessation of cigarette smoking, not only for males, but also for females. Not only cigarette, but tobacco in any form. Body weight management, overweight, underweight, both are bad. So the body weight should be within 20 to 27 kg per square meter if it is possible, BMI. Last three, reduction in caffeine content, moderation in alcohol, I think last two is really not very important. Taking a little alcohol or 2 to 3 cups of coffee does not make any difference. But last one is important, appropriate counseling, which sometimes we call tender loving care. And that can sometimes bring a confidence in the mind of the patient, which can help her to become pregnant spontaneously. Now, tubal flashing is one treatment, as you all know, that tubal flashing we used to do once as hydrotubation. But it started from the observation that when you do a hysterosalpingography, particularly with oil-based medium, the pregnancy rate increases. So that means mechanism is not very clear, but possibly it removes the debris from the tubes and increases the chances of pregnancy. So if you have done a hysterosalpingography, do not immediately rush to any follow-up treatment. Give the patient a little time so that there is an increased chance of spontaneous pregnancy. So clomiphene and IUI can be recommended as a follow-up treatment in these cases, and that increases the chances of pregnancy. Fallopian tube, there was another treatment which is possibly now of historical importance. They used to push sperm-rich fluid, just like a hystero, within the uterine cavity, so that it spilled out through the fallopian tubes. Now this is now discontinued now because better methods of treatment are available. This is only for historical importance. Specific therapeutic measures, ovulation-inducing drugs, clomiphene, aromatase, and gonadotropins. Any of them can be used in a case of infertile couple where the cause is not found. It is not necessary that an ovulation has to be proved. Even in ovulatory patient, sometimes these drugs can produce superovulation and can help the couple to get pregnant. So clomiphene citrate, as we all know, has been used for ages. Now, it is a reasonably good drug for anovulatory infertility, but sometimes can work even in those cases where you cannot positively demonstrate anovulation. But it has got its problem, as we all know, that it improves the ovulation rate, but actually interferes with the quality of the endometrium. And sometimes, even if you give a small dose, the rate of multiple pregnancy is high. It is not a happy news because high order pregnancy is generally associated with high risk for the mother as well as for the baby. Aromatase inhibitors, not many literature was available until very recently, because in many countries, aromatase inhibitors still is an off prescription drug for ovulation induction. This is used for many other causes, but not for ovulation induction. Even FDA has not approved it up till yet. In India, it was not used until about few years back, and it was not available even in India. But we all know that letrozole is a good drug for ovulation induction, and sometimes in many literature, it is better as regards ovulation induction rather than clomiphene. So we can use letrozole. There was once a sort of idea in people's mind that letrozole can produce congenital formation of the baby, but that has been dispelled completely now. We know it is a safe drug and can be used, and the results are generally better than clomiphene, even in cases of people with unexplained infertility. Gonadotropins, we all know, are drugs which are much better than clomiphene or letrozole in inducing ovulation, not necessarily in improving the number of pregnancies, but they require specialized sort of observation when you use clomiphene, because the chances of ovarian hyperstimulation is really genuine, and in case of gonadotropin, it is quite high. So the gonadotropin, though it gives a better result in case of unexplained infertility, but the dose is not actually very clear in what dose you will use this. And secondly, its price is a consideration for people in developing countries. And lastly, there is always a risk of ovarian hyperstimulation. So if you want to use gonadotropin in unexplained infertility, you must have the resources to observe this patient carefully so that they do not suffer from overstimulation. Intrauterine insemination, IUI in case of unexplained infertility. So a Cochrane review showed that IUI in unexplained infertility is associated with 8% pregnancy rate. When gonadotropin was combined with it improved from 8% to 18%. And we also have seen that by simple ovulation-inducing drug given orally, and if you follow this up with IUI, the results are generally inferior if you add gonadotropin also. It gives a better quality of egg, and possibly the result of IUI is better. An important thing is that you must document the development of a good ovum before you go for IUI. Doing IUI right and left is not going to improve the pregnancy rate. So just ensure that the patient has got a good egg, and then you do your IUI. And in that case, possibly you have to follow the usual norms that we associate with a good IUI procedure. So doing it haphazardly does not generally improve the pregnancy rate. If you combine aromatase inhibitor and IUI, the result is better than clomiphene and IUI. But as I have said before, the best result is if you combine aromatase inhibitor or clomiphene and gonadotropin in order to get a very good quality of egg. But when you get overstimulation, that do not continue. Just stop your stimulation procedure immediately. So when to perform IUI in unexplained infertility, best time of IUI is after documentation of LH search by a commercially available urinary kit from day 12 onwards. You go on testing every day till you find a LH search, and then you give the triggering. Just doing it any day is really not very effective. Second, you can monitor the follicular growth by serial TBS and give the triggering when the diameter of the follicle is 16 or 17 or 18 millimeter according to your own experience. And generally, we advise to do the insemination 36 to 48 hours later. Though there have been 1 or 2 papers which have shown that insemination anytime after triggering is generally equally effective, but physiologically we know that the ovulation occurs 36 to 48 hours after the ovulation triggering, so it is better just to maintain that time schedule. Controversy has also arisen whether a single IUI or 2 IUIs on 2 consecutive days gives better result. So some people have said that 2 consecutive IUIs may be better, but most people still believe that the single IUI followed by natural intercourse possibly is equally effective. So mostly we do not go for 2 consecutive IUIs as they are not very productive compared to single IUI. So how many times you can do it? The patient often asks. She is not becoming pregnant. So some investigators have shown that cumulative pregnancy rate increases as you increase the number of IUIs. So in case of 3, it was 18. In case of 6 IUIs, it was 30%. And one report shows that even if you go to 7 or 8 times, it can be up to 40%. But mostly it requires lots of tension on the part of the couple to go on with so many cycles of IUI. So we advise them not to do it more than 6 times. If they fail to conceive with 6 IUIs, it is possibly not wise to continue, because each IUI has got a psychological stress on the patient because she expects a pregnancy and a disappointment comes when she gets her period. So we generally advise IUIs should be done properly, and it should be done not more than 6 times. IVF or ICSI for unexplained infertility. IVF gives the highest pregnancy rate, as you all know, in the shortest interval. Currently, this is quite expensive for many developing countries. If where the service is not free or subsidized, there are some lucky countries where this service is provided free or subsidized in some situation. So the one Cochrane review showed that the rate of IVF compared to expected treatment was quite significant. 33.7% compared to 45.8%. And lastly, in women who are aged more than 37 years, the best pregnancy outcome will be by IVF compared to any other method. So there is no scope for trying other methods if the patient can afford and the age of the wife is more than 37 years with unexplained infertility, they should go straight away for IVF. If the patient's age is less than 35 years, then possibly you can go for a step-up protocol, starting one treatment after another. And this is mostly because of lack of facilities or lack of financial ability of the patient to continue with the IVF at the first sitting. So pregnancy in gonadotropin plus IUI in one study shows was 29.8% compared to much higher rate in case of IVF. So IVF facility, wherever available, should be availed by these people if they do not conceive after a sufficient time and if the age of the wife is more than 37 years. Now next is if the patient cannot have an IVF or even IUI repeatedly, what is the alternative? So many, and there are other couples also who will not go for IVF for other reason. And we have found, and many people also have found, that laparoscopy may be an alternative approach for them in unexplained infertility. How they work, we do not know. Many pathologies like functional closure of the tubes with sludge, the small polyp, adhesion, etc., which can only be diagnosed by laparoscopy and treated effectively at that particular time. So this is one treatment which is being recognized by more and more people in a low resource setting if the patient cannot go for ART. And our personal experience is also such that in case of unexplained infertility, even on laparoscopy, you do not find any obvious cause. Simple doing a laparoscopy, flushing chromatization and flushing of the tube actually increases the pregnancy rate. And in some cases, rate as high as 40 to 50% has been reported. So this is one treatment, poor man's IVF, you can try. So conclusion, there is no definite answer as what should be the best approach for unexplained infertility. The availability of resources, duration of infertility, age of the female partner, male partner query is important. Current review evidence suggests that the approach should be from a low to a high technology, if time permit. And because this is less, this puts less pressure on the patient's pocket money. And in this case, even in many developing countries, one course of IVF will cost a man's 6 months' salary, which is not easy to afford. So younger women, treatment should be stepwise from expectant to clomiphene to IUI and ultimately to possibly IVF. In elderly patient, it will be reversed. That means the IVF should be the first choice. And for those who cannot afford IVF, but their age is increasing, in that case, possibly laparoscopy can be an alternate approach. This is a very good algorithm presented in a paper by Ray et al., and which will show the actual procedure which one should follow if a patient gets with unexplained infertility, and you can look up at it and possibly can get a better idea how to triage your patients according to their situation. There are lots of guidelines also. I do not want to go into that. And there I'll just talk about 2 reviews. I have shown here, if anybody is interested, they can go through this paper, very valuable, very informative papers, which will tell you about the situation of unexplained infertility and how to deal with this problem, particularly in low resource situation. So thank you very much.
Thank you, sir. Thank you very much for your excellent presentation and making a very difficult topic in a much easier way. Our next speaker is Professor Parveen Fatima, Madam. Professor Parveen Fatima is the Secretary General, Fertility Sterility Society, Bangladesh, former chair and professor, Reproductive Endocrinology and Infertility of Bangabandhu Sheikh Mujib Medical University. She is the Vice President of EASB, past Secretary General OGSB. May I request Professor Parveen Fatima, Madam, to speak on 4 decades of ART. Professor Parveen Fatima, Madam. Professor Parveen Fatima, Madam.
Yes.
Madam, start করতে পারেন।
হ্যাঁ, দাঁড়াও। এই শাহিন,
স্ক্রিন শেয়ার যান আপা, নিচে একটা স্ক্রিন শেয়ার লেখা আছে, ওখানে ক্লিক করলে আপনি যেতে পারবেন আপনার স্ক্রিনে। হ্যাঁ, এই তো আপা চলে গেছে।
হ্যাঁ, আই এম ভিজিবল নাও।
ওকে, আপা জাস্ট নিচে ক্লিক করে আপনি এটাকে ফুল স্ক্রিন করে নেন।
Thank you very much, respected chairpersons and the participants of this first session of our Fertility and Sterility Society of first International Virtual Scientific Conference. I welcome you all for this session. And you have already heard from our renowned professor, our sir, about unexplained infertility. That is a very big chapter also. And about 10 to 20% of the patients suffer from that also. But what about patients who are undergoing ART? So I just have gone through the 40 years of ART that we have passed already. In the past 4 decades, the technological development in the field of ART is beyond imaginations and has become increasingly effective and popular. Millions of infants born in the world as a result of ART. During the 1920s to 60s, multiple innovations and discoveries helped lay down the foundation for IVF. So it has a long history, and the history, the starting is always with the technique done on animals, which is tested, and then the attempts are done on the humans. That is the scenario that is always happening and has to secure us with testing the animals, whether it's fit to be done on the humans. The first case of embryo transplantation in rabbits was done by Walter in 1890. In the 90s of 18,000, what happened? After that, there was a long delay to start the process. And in 1934, Pincus raised the possibility that mammalian eggs can undergo normal development in vitro. And Chang achieved in 1959 the birth of a rabbit by IVF. So the scenario started. This pregnancy proved that embryo fertilized in a lab can be successfully transferred to the womb and carried to term. Since then, researchers began to replicate IVF treatment in humans. So the first attempt on humans occurred in the early 1970s. An Australian team in 1973 succeeded with IVF, but the pregnancy was not continued. And then in 1976, an ectopic pregnancy from IVF was reported, and it was by Patrick Steptoe and Bob Edwards with their 102nd human embryo transfer. They also had to go for more than 100 transfer to achieve the world's first IVF child, Louis Brown, on 25th July 1978. So this is the history. What about the initial days of technical development? Initially, oocytes were retrieved by laparoscopy, and then Robert Edwards and Howard Jones in Johns Hopkins Hospital in USA attempted to fertilize human oocytes in vitro. And in 1973, the first IVF pregnancy was reported. And besides this, there was need for improvement in the laboratory and the years that has been used. Since 1976, Menizo, he developed the world's first B2 culture medium, which is known as the French medium. And that also gave us the laboratory support that we needed for development of the embryos in the lab. This is Louis Brown, world's first IVF child. And you are seeing the mother and the persons who were contributed to this, to the first live birth from in vitro fertilization. The birth of Louis Brown was the starting point of a fertility revolution with many new developments, but the basic concept of in vitro fertilization is unchanged. Refinements in the technique has been introduced, and all steps, genetic evaluation of developing embryos and cryopreservation, ICSI, optimized ET techniques, all has contributed to its success. Advances in the past 40 years was significant in the field of ART. In the first decade of these 40 years, advances in the greater efficiency and accessibility of ART with higher success rate was in the general public. From the second decade onward, innovations and refinements in the technology and the door for male infertility by ICSI, MISA, and TISA was opened. Egg retrievals, which was initially done with laparoscopy, was converted ultrasound-based vaginal retrievals, and the very good intervention with vitrification, which is known as the flash freezing of eggs and embryos, and even the ovarian tissues, sperms, everything is now cryopreserved by the process of vitrification, which takes very small time and very small amount of media is used, and there is no ice crystal. So the recovery is very good. PGD provides couples with sex-linked disease and genetic disorders to be able to have children free of the condition and increase the success rate of ART by aneuploidy screening. So there are good things for couples who have some inherent disease. Oocyte cryopreservation and ovarian tissue transplantation provides options for women who needs to delay childbearing. So this is also a social need, that when the women are going to take some more time before they conceive, they want to have a pregnancy, they can preserve their fertility for a long time if they want it. This is the historical development of ART. I told it is 1978 that Louis Brown, the first IVF baby, was born, and in 1982, eggs was retrieved by ultrasound. That is also a big achievement. And in 1983, first baby was born after cryopreservation of embryo. And in 1985, delivery by gestational surrogacy occurred. So in 1992, first ICSI baby, and in 2004, baby was born after freezing of ovarian tissue. So a long history is there, and it was in 2010 that Bob Edwards was awarded the Nobel Prize. This also took some time for the world to think and rethink. And in 2014, baby born after uterine transplantation. So IVF gave these chances to these women to conceive. And next came in 2016, the 3-parent baby born through contribution by the mitochondria. This is the world's first international IVF conference in Barnhall, 1981. All the people interested in ART and infertility management gathered that day, who were at that time working, and this was the starting point of a conference for reviewing all the things that can be done. So there was also, laboratory also underwent almost complete metamorphosis since the early days of IVF, because the embryo culture systems has to be improved. Culture media was changed, and appropriate medias were coming up. Training, the person who started was with interest, but they were scientists, they were persons working in the labs, but as the subject has to be taken over, the training of the gynecologist, embryologist was necessary, and that is also now being done, which was not initially available. Equipment and techniques have continued to improve, and it was in 1985 that add-on procedures were added in, which improved the IVF outcomes. The present IVF success rate today are 4 times higher than that was 3 decades ago, despite the less number of embryo being transferred now, because the embryo transfer is changing to single embryo transfer. So This is the scenario, the ART lab today, which is morphologically based, fish-based. Air quality is very much controlled there. Vitrification is done. Cleavage stage and blastocyst cultures are done. And this is the laboratory work now being done in almost many countries, many places. But the laboratory, what we want in the next generations and in the coming days is morphological biomarkers based, metabolic based biomarkers, genetic based biomarkers, and proteomic based biomarkers. This for the better outcome of IVF. But at the same time, what is happening? People are thinking about the cost because we want it for as much benefit can be given to the infertile patients. So IVF without lab was launched in 2016, and many babies has been already born with this procedure. So what is next coming up is and which procedures will be more convenient for the developing countries. In the poor middle income countries is to be thought, and we have to think and proceed like that. So this is the scenario in human reproduction update in 2021 March April. They are showing that the low and middle income countries, the limiting factor is cost initiative for ART. It has been shown Bangladesh is also the difficulty is the cost barrier. So most of the countries has the cost barrier problem, but in some other countries the other factors are also there. But they have in South Asia, India and Bangladesh, the cost, it has become a barrier for us. The technological developments that during the last 4 decades is beyond imaginations. It's starting from the improvement in the drugs, because there are drugs which are now getting safer and safer. The complications of multiple pregnancy, the complications of hyperstimulation was dreaded before. Intracytoplasmic sperm injection has treatment for male fertility. Now embryo culture can be prolonged, and even some of the centers are going beyond 5 days. Live camera, where you get the footage for 24 hours, can monitor your cell divisions. Chromosomal screening by PGD, mitochondrial donation by 3-parent IVF, vitrification, uterine transplantation, and re-energizing aging cells. Because aging is a process, especially the omens that Sir has told already. The aging causes more problems in the getting a pregnancy. So these are being considered, and there is now helping hands for them being tried, and it is coming up. The global change, the change that has already happened is ultrasound guided oocyte retrieval, embryo cryopreservation, and ovum cryopreservation, choosing the best embryo for transfer. This is now the point where we have to consider which embryo is the best to transfer, because we are heading for single embryo transfer. Genetic assessment with PGD, metabolic assessment of embryo competence is also coming up. Fertility preservation for cancer patients, male fertility preservation, social fertility preservation, and healthy outcome for chronic and genetic disease. So the IVF has helped us to help the people in these respects. Donor recruitment strategies is also in the donor is being accepted in many. It is not still in our country, but that also is giving a childless couple of family to build a family, and the new technologies has to be considered. So the thing beside these, what we are to think, we have to minimize multiple pregnancies to give a better outcome for the mother and the child. Patient's load is decreased when there is single pregnancy, and stress is also reduced, maximize the success rate with single embryo transfer. Newer approach to ovarian stimulations is coming up. Always it is changing. People are finding out ways how to minimize the stimulations and get the optimum number of oocytes. Then the oocyte maturation in the lab is being done. Spermates as gametes are being used. Culture media, oocyte manipulation, and the blastocyst transfer. Culture media and the oocyte manipulation is also being very much encouraged in the lab for developing the procedures. So we need the sperm, we need the ovum. What about sperm selection for improving IVF and ICSI outcome? Sperm selection is now based on sperm morphology, IMSI. So, but the other ways of getting better sperms, the magnetic activated cell sorting is also tried in many centers. Then the newer techniques that is going to be included in the ART is the microfluidics. Sperm selection based on sperm motility through the microfluidics is also going to give us advancement for selecting the sperms which cause the best pregnancies. And what about the slow swimming sperm? There are sperms who are moving slowly, but they have their DNA content intact. The German scientists developed a unique solution, the sperm bot. This is the sperm bot, which has a device attached to the sperm. This is automatically the slow-moving sperms get attached with this, and they start moving towards the oocyte. It's a very good technique, very wonderful technique where these sperms can now fertilize the eggs. These are the advancement. And the advancement with microfluidics is great. From droplet microfluidic to microfluidics, the world is advancing in a speed that we, the developing countries, has to catch if we want to go to that extent. So what about the re-energizing fertility? So the Agumon technique, where the precursor eggs from the omen is used to for getting the mitochondria, so that the embryo that develops is a good quality embryo and gives us a success. And not only that, there is plasmic transfer, where the cytoplasm of third-party donor is inserted along with the sperm, so that this is the three parent combinations. And this also, the DNA from the mitochondria is there, and the nucleus is actually the mother's nucleus. So this is the three parent techniques. These are also being tried, and especially where there are difficulties, where there is some genetic problems with the mitochondria, or the aging process is there. So these can be, we can help our aged group and the persons who have genetic problems with these techniques. What about the cryopreservation? Sperm, egg, and embryo is cryopreserved over in biopsy are also being cryopreserved. So with cryopreservation of oocyte, the egg banks are developed for the donor oocyte cycles. This is allowed in many of the countries. Women who want to preserve their fertility can go for oocyte cryopreservation. Fertility preservation for cancer patient is a big issue, because we have to talk with the cancer patient. Their cancers are in the young children, young group. The young group is suffering, and then at the end of their treatment, when they survive, they find that they have lost a lot of enthusiasm in their life, and they cannot make a family. So these people, we must also give them a chance. We must also create awareness about them so that they don't feel neglected in their future life. So where we were 40 years back, this is Louise Brown. She's holding the jar in 2013, where her incubator, her embryos were incubated. And this is the jar, and the time-lapse incubators now, that is the latest incubator. So this is the time-lapse incubators. This is the change that has occurred for embryo selections and maximum potentiality of getting a pregnancy. And from these bell jars, now we are over here. The 21st century has gone to that extent. The culture medias also, culture systems, there is a lot of change. The CO2 temperature and walk has to be controlled, and maximum from the mid-1990s, the maximum IVF laboratories adopt the closed under oil culture systems. So these are also being shown where to minimize the impact of environment also, so that we have no problem with the child that is going to come back. Genetic testing is also there to give the pregnancy a better chance, and to for the recurrent pregnancy loss also, they select the best embryo and the good embryo, and especially with the advanced maternal age, this can be taken into consideration to decrease the so that the aneuploidy can be removed. Time-lapse imaging is not only the thing that is coming up. The artificial intelligence, that is also going to be in giving a revelation in the ARTs. The sperm cell, there are 7 points there that is being considered with artificial intelligence. The sperm cells classification is there, oocyte selections, best oocyte selections, and the best embryo selection, along with robotic management. So the we don't need to manipulate ourselves. The prediction outcomes is also given there. Cost-effective management and clinical decision systems is also included there. So the artificial intelligence that is coming up, it will be, it is also being taken into consideration by many of the laboratories now. What is future for development in IVF lab? The automation of the ICSI. The ICSI needs a very technical hand to work with the ICSI micromanipulators and the microscope that is used for that. That is going to be changed into automation. That will give a big leap to us. And the proper selection of the sperms, that is also very important. Which sperm will give the best result for us? And the lab is coming, going to be embryologist free, lab in a chip, that will give us the best embryos, best selection, best outcome for the ART. So we will not only improve in those things, but we have to think of the safety of our woman, safety of the child that is born by ART. So the minimum stimulation protocols and the GNA agonists to trigger ovulation to avoid OHSS, ovarian response prediction by AMH, preventing the biggest health risks of fertility treatment, the multiple pregnancy by single embryo transfer. So these things has to be considered for the woman also, and more things will be coming up to be considered. And what about the health of the child born from ART? There is a question that whether congenital anomaly will be more in them. Still, in some places, small changes are there. The literature has already quoted there can be a little increase in congenital anomalies, but not everybody doesn't agree with it. Donated gametes study found events that occur in early development, including ovarian stimulation, manipulation of the embryo, and extra hormones that is given for the support of the treatment, can impact gene health or epigenetics, but these effects are short-lived. That is a good thing, that this effect doesn't stay long. So the assisted reproductive technology has effect on babies gene, which is largely being corrected by adulthood. So as the child grows, some of these epigenetic and the impacts of the genes are being corrected by the time they become adult. That is also has already been proved by the donated gametes. So that is also a consoling thing for us, so that our next generation has a good health in the future. So decades of improvement in reproductive medicine. What are the achievements? Ovulation-inducing drugs, in summary, it is like this, that from clomiphene to gonadotropin to GnRH analog to in vitro maturations, ovum retrievals from laparoscopy to transvaginal, ultrasound-based, and the conquest of the male factor infertility, refined techniques for culture to blastocyst stage and transfer of single embryo transfer, vitrifications, implantation, pre-implantation genetic diagnosis and screening, ART laboratory from morphologic to metabolic assessment. So re-energizing fertility, re-energizing aging cells by egg freezing, recovery of mitochondrial damage from aging or from mitochondrial disease, ovarian cryopreservation, lab-grown eggs are coming, lab-grown sperms are coming. So the sperm plot is coming. Acupuncture as a complementary and alternative therapy. That also has shown that as especially for the unexplained infertility, they are giving a step forward. Transplant surgery is also coming. There are children born from uterine transplant already, many children now born, and the ovarian transplant is also a necessity for the future. So, thank you very much for the patient hearing. The future of reproductive medicine holds many promises and advances. And although it's hard to exactly interpret where IVF and fertility treatment will be in the next 40 years, only time will say what future holds. Thank you for the time that you have given to me. Thank you very much.
Thank you, madam. Thank you for your excellent presentation and for sharing the brief history of the 4 decades of ART. Thank you, madam. We have 2 eminent gynecologists as chairperson to today's session. Professor Anora Begum. May I request Professor Anora Begum, madam, to speak on first presentation of Professor T. Chaudhary, sir. May I request Professor Anora Begum, madam, to share her thoughts and remarks on sir's presentation.
Thank you, Farjana. Assalamu alaikum and very good morning to everybody. First of all, I want to thank both the speakers for their brilliant presentation. Today's first speaker was Professor T. Chaudhary. Professor Chaudhary, he has presented a very important topic, that is an unexplained infertility. He has very clearly spoke A to Z of the unexplained infertility. The presentation was clear, concise, and complete. We have learned a lot from his presentation, and his conclusion or take-home message was very much clinically oriented and will be beneficial for all the listeners, whether they are gynecologists, general gynecologists, or infertility established specialists. I will say a few words about the general gynecologist, what we do in our practical life when a patient comes with the infertility. As sir has rightly said that there is no definite definition for these infertility patients because we do not know whether they have got any cause or not. So what we do, the general gynecologist, we just take a good history and also do the clinical examination and a few investigation, that is a blood count, blood sugar, thyroid function test, and nowadays we also do AMH, ultrasound of the pelvic organ, and semen analysis. Now, if we find no problem in this investigation, probably she has got some problem somewhere. But what we do for these patients, we also treat them for sometimes, especially if the patient is young. We just give them assurance, very good assurance, and also advise them a few lifestyle modifications. And especially if she is overweight or if she's very thin, then to improve her health condition, ask her to quit smoking or something like that, and also if she is anemic, we just correct the anemia, and also ask her to change her food habits, like to avoid the fast foods and also the rich foods, and to have plenty of vegetables and fresh food, so that they have got plenty of vitamins and minerals. And also advise them about timely coitus, because sometimes, the husband is in Dhaka, the wife is in our village home, and husband went to the home once in a month, and that if they do not know what is the timely coitus, it becomes difficult for them to get pregnant. And the drugs we usually use nowadays, a few drugs also do you use by general gynecologists, like letrozole, sometimes chloroquine citrus. Nowadays we usually prescribe aromatase inhibitor and multivitamins. And we do not go for the just general, we do not go for the gonadotropin because it needs some special monitoring. And if they get pregnant, now we are very lucky that many a time they get pregnant. But if they do not get pregnant, then also we have no problem. We send them to the infertility specialist. Finally, again, I want to echo Professor Tia Choudhury that what we general gynecologists are happy as we currently are. Thank you all. Thank you.
Now may I request Professor Ifatara Madam, our next chairperson, to speak on the presentation of Professor Parveen Fatima Madam. Professor Ifatara Madam.
Thank you, Dr. Farzana, for your welcome. Honorable speakers, senior and junior gynecologists, a very good morning and salam to everyone. This is the month of December, Victory Month. I pay tributes to thousands of martyrs of our country and our neighboring country, India, who laid down their lives for this cause. You are the thousand wheels that blow. You are the diamond glint on the snow. You are the sunlight on the ripened grains. You are the gentle autumn rain. You are everywhere amongst us. Salam to everyone, all the martyrs. We have about the presentation of Professor Parveen Fatma. She has very nicely dealt about the 4 decades, starting from the lab works, starting from the ovum retrieval, starting from the all the modified protocols, the newer methods, and last of all, the artificial intelligence. Actually, the artificial intelligence is coming and playing everywhere. It is playing in our part, for example, even in our day-to-day activities, the artificial intelligence is very much there. We have come a very long way, but we have gone a far way, because for our country, we know that infertility, subfertility is a burning problem. Because in our day-to-day chamber, what we see every 3rd patient or 4th patient is a subfertile or infertile couple. So we have to deal with it. So for our country context, we have to make some modification, because sir was rightly saying that laparoscopy is a poor man's IVF. So things like that should be developed for our country. We have to make some patient-friendly approaches for the community level, because I work in a semi-urban area where most of the patients are subfertile. I do 2 or 3 basic investigations and give the treatment protocol. And ultimately, by the grace of Allah, I have seen that most of the patient can conceive. So these community-oriented approaches should be there, and workshops should be there to make our young gynecologists more aware so that they can give service everywhere. I again thank Professor Parveen Fatma for her brilliant presentation of 4 decades starting from animal lab to the artificial intelligence. Thank you, everybody.
Thank you, madam. Thank you for your remarks. Now, may I request my co-moderator, Dr. Farzana Rashid, to wrap up the session.
Thank you very much, Dr. Farzana Diba Appa. On behalf of Fertility Society of Bangladesh, I would like to thank you, our honorable chairperson, eminent speakers, and all the audience who were present today in this session. As we are lag behind the time, now I would directly go forward to the next session, and I would like to hand over the session charge to the reporter of the second session of today's conference, Dr. Salma. The session is charged over to Dr. Salma. Thank you very much.
Ladies and gentlemen, participants from home and abroad, good morning. I'm Dr. Salma, currently working as Registrar in Fertility and IVF Center of Dhaka Medical College Hospital. Welcome you all to 6th International Virtual Scientific Conference of Fertility and Sterility Society of Bangladesh. This is the first day of the conference, and now we are in the second session. And the session is sponsored by Popular Pharmaceuticals. In this session, we are honored to have among us the two legendary professors of our country as chairperson and three very renowned speakers from abroad. And the session is moderated by Dr. Joyashree Saha. She is the Associate Professor of Department of Gynae and Obstetrics, Popular Medical College and Hospital, Dhaka. Now, I would like to request Dr. Joyashree Saha to conduct the session from now onwards. Thank you.
Thank you, Dr. It's my pleasure and feel proud to be a prestigious part of this interesting session. We have three renowned speakers in our today's session from abroad, and undoubtedly we will be very benefited from their deliberation. The speakers are requested to complete their presentation on time. Before 2 minutes, we will give the reminder. If anyone have any question, please give it in the chat box, which will be discussed at the end of the session if time permits. Now let's introduce our two chairperson of today's session. First one, Professor Kohinoor Begum. She is the professor of Obs-Gynae Department of Popular Medical College, and she was the past president of OGSB, and now she is the vice president of Bangladesh College of Physician and Surgeon. Our second chairperson is Professor Farhana Dawan. She is the deputy secretary of General Suffolk and president-elect of OGSB, and now working as the head of the Department of Gynae in Ibn Sina Medical College, Dhaka. And she was the Deputy National Coordinator of FIGO PP IUD Project, Bangladesh. Now I request Professor Kohinoor Begum, Madam, to introduce our first speaker. Madam.
Assalamu alaikum. Good morning to everybody. Ladies and gentlemen, we have just completed a very important session on unexplained infertility and ART. And this session is also very important for us. There are three important speakers in this session. Our first speaker is Professor Budi Wike from Indonesia. Professor Budi is immediate past president of Aspire, General Secretary of Asian Society of Fertility Preservation, Chairperson of National Health Technology Assessment of University of Republic of Indonesia, Chairman of International Relationship Committee of Indonesian Medical Association, and the past president of Indonesian Association of IVF. And her topic is premature ovarian insufficiency, what to do. Unfortunately, he is not personally present online, but we will be listening a recorded presentation by Professor Budi. So let us enjoy the presentation.
Good afternoon, everyone. First of all, I'd like to thank to Fertility and Sterility Society Bangladesh, who has already inviting me to this very prestigious meeting, and congratulations to my friends, Professor Maruf, there's already been success in hosting this very beautiful event. So I'd like to present my topic this afternoon regarding the primary ovarian insufficiency and what should we do or what to do. We know that premature ovarian insufficiency is also the same with the premature ovarian failure. Then we should be notice to our patient that not to give up. What is the primary ovarian insufficiency? Actually, this is the disorder of infertility that caused by cessation of ovarian function before the age of 40 years. And it's characterized by the occurrence of amenorrhea, low estrogen levels, and elevated follicle stimulating hormone levels in the menopausal range. And if you look these figures, that age at menopause is normally distributed with a mean of 51 years in a range of between 40 and 60 years. Menopause many years before the age of 40 years is a non-physiological disorder and the end stage of primary ovarian insufficiency. You can see here, actually the level of the menopause was approximately happened in the age of 50 years old. And this is that we call this under 40 years old. This happened because of primary ovarian insufficiency. And then this is, for example, the loss of follicles in women undergoing chemotherapy, even it has happened in the patient less than 20 years old. The primary ovarian insufficiency is a more accurate term for premature ovarian failure. This term also more scientifically accurate. And then the POI is not only the end of ovarian function, more accurate, but also informative for patients who may not experience at the time of diagnosis. If you look this one, that primary ovarian insufficiency also less emotive than the formerly used premature ovarian failure. Roughly, this happened in 1 in 100 women, and it is often diagnosis extremely delayed. And this is the number of papers retrieved in PubMed in total, and in the last 5 years, in the 2015s, I think the most frequent terminology are primary ovarian insufficiency, followed by premature ovarian failure, and also sometimes we call premature ovarian insufficiency. The term POI may be preceded by descriptor that identify the severity of ovarian dysfunction. And this is the clinical state is overt, level will be elevated, fecundity always, of course, reduced, and menses irregular or even absent. And if you look this one, healthy and decreased ovarian follicular reserve with increased age and change in the concentration of ovarian and hypothalamo-pituitary hormones. This is the decreased ovarian reserve. We can see because of declining of inhibin B, of course, FSH increase, and also AMH is very low because of decreasing the antral follicle count. POI can result from early exhaustion of the follicle pool, although the underlying mechanism can differ from those that cause natural menopause. This is the natural menopause. We can see here the follicle, the number of follicle diminish, and also the serum AMH level is declined. And in the POI, developmental reduction in the number of primary follicles, the accelerated rate of primary follicle recruitment, or it has happened because of increased atresia or destruction of the follicles by autoimmune antibody. So it can be happen because of accelerated follicle primordial in the recruitment, and then increased rate of atresia or destruction of follicles by autoimmune antibody. And this is the cause of primary ovarian insufficiency because of genetics, autoimmune, metabolics, infectious, anatomical, and iatrogenic, such as ovarian surgery, chemotherapy, and radiotherapy. This is for example, the cancer treatment because it has gonadotoxic effect and result in POI or acute POI. Sometimes they recover, although the pre-treatment level are not reached, and ovarian function ceases at an earlier age than in healthy women. And this is it's happened when the abdominal radiotherapy or chemotherapy repeated cycle with alkylating agents, ovarian function may not recover and met level remain undetectable. And this is, if we look this one, this is a different gonadotoxic effect by the chemotherapy. The high risk is cyclophosphamide, alkylating agent, medium risk is platinum, and then low risk including MTX. And then this one is radiotherapy, high risk, total body irradiation. And then this is the medium risk, and this is the low risk. If you look this one, anti-Mullerian hormone levels in female cancer patients of reproductive age in Indonesia, this is the cancer group. We can see here the MS level is significantly different. This is between gynecological cancer and then non-gynecological cancer. There is no significantly difference. So it just explains that the cancer also will be make an influence to the ovarian reserve. So that's why it's should be very careful if you want to preserve fertility in our cancer patient. So what is the problems in primary ovarian insufficiency? Of course, the number one is menopausal problem, and the number two is reproduction, particularly is infertility, and also the menstruation. This is the condition associated with POI. They will suffering from psychological function, infertility, and increases risk of cardiovascular disease, and then loss of bone density and fracture risk, comorbidity, and also increased risk of the premature death. So what should we do in infertility patients in POI? I think this is the study by Kawamura, doing in vitro activation of follicles using the fragmentation of ovarian strips to cubes. They also can use the drugs, P10 inhibitor and PI3K stimulator. And then after that, they also doing the transplantations, Pinich rosa or fallopian tubes, and then the patient underwent the IVF after the cortex was transplanted. And the other study also by our student, our group, and Dr. Mila with Telfer, she looked at the crosstalk between P10, PI3K, and EKT signaling with DNA damage in all sites, and how the implication for primordial follicle activations, oocyte quality, and aging. We know that P10 and PI3K is a major signaling pathway governing primary follicle recruitment and growth. Accelerated primary follicle activation through this way may result in compromised DNA damage response. So if we look this one, the high intracellular level of AKT has been reported to increase DNA damage, replace nuclear translocations of BRCA1, and compromise homologous recombinase in breast cancer patients. So that's why if we do the in vitro activation of primary follicles, there is some risk to make the DNA damage response. So I think we should be very careful. And this is actually what the Kawamura did. the in vitro activation by the IVA, drug-free IVA. They do the fermentation incisions by doing mechanical signal, and it will they do the incision, drilling, or wet resection, fragmentation. It will increasing actin polymerization and make hyposignaling disruption to hippopathway genes, and then will make a biochemical signal. It will increasing growth factors and increasing the apoptosis inhibitor, so the follicles can be growth. If you look this one in the follicle genesis process, yeah, of course, this one is the poor ovarian response and primary ovarian insufficiency. It's just what happened recently. We can offering the drug-free IVA. However, if in the prolonged POI, IVA, it should be induced by the drug. Might be not by, yeah, it should be induced by drug IVA. This is by using the drug-free IVA, make fragmentation, segmentation. Also in resistant ovary syndrome and PCOS, we know that we do also activation by doing ovarian drilling, wet resection, or ovarian incision. It's almost the same pathophysiology with doing the hyposignaling, disrupting or hyposignaling pathway in the ovary. If you look at the guidelines, no intervention has been reliable to show increased ovarian activity and natural conception rate. So that's why women should be reassured that the opportunity for fertility preservations almost missed. And even the women suffering from premature ovarian insufficiency should be reassured that spontaneous pregnancy after idiopathic POI or most of form of chemotherapy do not show any higher obstetric or neonatal risk than in the general population. So that's why there is some narrow window of opportunity to make the POI patient getting pregnant. And this is what we see ovarian reserve, and then this is in the POI patient. Sometimes they have a good ovarian reserve, and then if they have the high AMH, and then of course this is the best with good ovarian reserve with high AMH, good ovarian with low AMH. Also, it's become a problem because there is accelerated of the follicle recruitment. It is also can induce POI, or in this situation, the patient itself the very low ovarian reserve with the high AMH is also become a trouble. It is better than the small ovarian reserve with low serum AMH is become patient rapidly loss of their ovarian reserve. So that's why people trying to establish the potential therapeutic application of human AMH analog in reproductive medicine, since we know that AMH mutations with the use in vitro bioactivity are related to POI. So that's why might be if we give AMH in the POI patients, yeah, it will inhibit initial follicle recruitment by AMH agonists. Yeah, application include contraception, delay of onset of menopause, fertility preservation, and infertility treatment, and then it's very good for POI patient. On the other hand, AMH antagonists might be good for releasing arrested selection of dominant follicle, such as happen in PCOS patient. And the other things also very important, how we choose adjuvant treatment strategies during ovarian stimulation for women and poor responder women. If you look this ones, the most frequent study is doing for recombinant NH supplementation, growth hormone, letrozole, DHCA, CC, testosterone, estradiol, coenzyme Q10, and SCG. However, only two giving a significant result. They are coenzyme Q10 with a relative risk 2.2 and the HCA with relative risk 2.46. And again, we can see here coenzyme Q10 and the HCA, they have a good odds ratio compared to others in with primary outcome in clinical pregnancy. You can see also the ROC curve. This one is the coenzyme Q10 and the HCA. It's better than others. And most of almost all patients with POI would persist on multiple attempts to achieve the desired pregnancy using their own eggs. So that's why the adjustment add-on is very, very interesting. This one's people trying to give adjustment add-on to improve the response to ovarian stimulation in the trigger, during gamete preparation, during embryo assistance, luteal phase support, implantation enhancement, embryo selection, embryo endometrial synchrony, early pregnancy support, and also technical options. This is what the people do, trying to enhance the pregnancy rate in the POI patients. This is what happened if we give growth hormone supplementations. Actually, growth hormone supplementation will increasing the granulosal cells mitochondria DNA copy number compared to the control, so that may improve the oocyte quality and developmental competence. If you look these ones in the implantation embryo. This is for overall growth hormone increasing the mitochondria number in cumulus glandular cells. It's better than the control. Also, the HCA, even this is many evidence and limited and evidence, and also still very pros and cons. However, that the HCA quantitative analysis of the patient receiving the HCA, they will increasing the androgen receptors and FSS receptor messenger RNA expressions in the granulosal cell. So that's why they will give the more better oocyte quality and better embryo quality because of increasing FSS receptor and androgen receptor. It will improve the response of FSS receptor toward recombinant FSH, and then they will give more oocyte and also more embryo. And the last is about coenzyme Q10, that it will restore oocyte mitochondrial function and fertility during reproductive aging. We know that in aging, the aging female is accompanied by mitochondrial dysfunction associated with decreased oxidative phosphorylation and reduced ATP levels. And if you look this one, coenzyme Q10 will rescue spindle defects in aging oocyte, and also it will improve chromosomal misalignment and spindle defect. Yeah, this one in the old patient. This is in the old patient again. The misalignment chromosome will improve by giving coenzyme Q10, actually with high dosage, 3 times by 200 milligrams daily. So the last, if we have the POI patient, if we want to do the ovarian stimulation, of course, we should check whether antral follicle was detected or not detected. And if the antral follicle was not detected, we can give supplementation, precursor androgen or precursor androgens, coenzyme Q10, or even anti-estrogens. And then if the antral follicle was detected, of course, we can do the start simulation or even random start simulations with high dose gonadotropin, LH supplementation, or growth hormone supplementations, and then coenzyme Q10. We can give the coenzyme Q10 supplementations, and with the patient doing oocyte retrieval, even we can plan for double stim or dual stimulation. And as a take-home message, POI was happened because of ovarian function cessation before 40 years old, and developmental reduction, accelerated recruitment and destruction of increase of follicles are the main contributing factors to boy with the problem infertility and menopause-related health symptoms. Releasing the residual follicles should be considered for getting off outside in POI patients. Might be when AMH agonist is one of potential future treatment in POI patients. And there is some evidence that coenzyme Q10 and DHEA even is revealed potential improvement of IVF outcome, including embryo quality and clinical pregnancy, and growth hormone improve number outside, good quality embryo and clinical pregnancy, including live birth, because increasing of mitochondria DNA copy in the gram cells. Even SLA guidelines still not recommended regular use some of adjuvant prior ovarian stimulations, and the concept of ovarian aging is most probably correlated with mitochondrial dysfunction. So I think this is my presentation. Thank you very much for your kind attention. Good afternoon.
Thank you, sir, for your excellent presentation. Now I am requesting Professor Farhana Dawan, Madam, to introduce our second speaker. Madam, please.
Thank you, Dr. Jayasree. Respected dignitaries, chairs, speakers of this virtual scientific conference of FSSB, a very good day to you all. I'm really honored to chair this very important session on the occasion of 6th International Virtual Conference of FSSB. And I would like to thank the organizers, especially Dr. Maruf Siddiqui, for giving this opportunity. Now, we have already listened to a very interesting presentation by Dr. Budi Viveki, and now we are on to the next presentation by Professor Claire Bothroyd. And Professor Claire Bothroyd is the consultant endocrinologist and gynecologist with subspecialty qualification in reproductive endocrinology and infertility. She is the president of Australian and New Zealand specialized in reproductive endocrinology and infertility, and she is the president-elect Asia Pacific Initiative of Reproductive Endocrinology, and she is at present the owner of Care Infertility, Brisbane, Queensland. So, dear audience, please welcome Professor Claire Bothroyd. Her topic is correlation of AMH and PCO. What is the clinical significance? Over to you, Madam, for your presentation.
Thank you very much for that kind introduction, and it's lovely to see so many faces that I knew at Aspire and met, and so I'm sorry that we're doing it virtually, but at least we are doing it virtually, even if we can't meet face to face. I'd like to thank the organising committee for asking me to do this presentation, and I hope that you can see the slides. Can the chair confirm that for me?
Yes, madam, we can see. Please.
That's great. That's good. Okay, which is a very interesting topic, the correlation of AMH and PCOS. What is the significance? And I'm hoping over the next 20 minutes that I will share with you some of the recent work in this area. I do have a number of dualities, but I don't think any of them affect this talk, but they are here for the record. The scheme I'm going to take is a little bit of background physiology, but I'm going to try and answer 5 questions. Can AMH be used as a diagnostic test for PCOS today? Can AMH tell us anything about the pathogenesis of PCOS? Does AMH predict the response to treatment? Is AMH changed by the treatment of PCOS? And does AMH predict metabolic disease or phenotype of PCOS? So, the little bit of background physiology, this audience will all know that, of course, AMH is secreted by preantral and antral follicles, and it tends to decline in age after the woman reaches the age of 30. And it's largely constant throughout the menstrual cycle. There is a little drop around the time of ovulation, and I will refer to that a little bit later. This is a compilation of Scott Nelson's work. Of course, we haven't had an AMH assay measured over a woman's lifespan, so this is a compilation of many, many data sets. And you can see that the changes in puberty are very, in adolescence, are really quite difficult and unpredictable, but there is a huge range of AMH levels in women in their mid-20s and so on, but you see that clear decline from the age of 30. And of course, some women are in a low age, and I'm sure that Virgilio will start covering off on some of this in the next talk. Okay, let's do the first question. Can AMH be used as a diagnostic test for PCOS? Now, when we talk about diagnostic tests, we have to go back to the good old Thomas Banks in the early 18th century in England, who, of course, had his colleague posthumously print his preliminary work on probability and statistics that really gives us the foundation for what is a good test. And we want to have measures of sensitivity that are high and measures of specificity that are also high. But of course, Tom Bayes reminds us that the population that we test, or the pre-test probability, is very important because it's about the positive predictive value and the negative predictive value. And of course, the population that we're trying to diagnose PCOS is something which is very important. Are we going to try and diagnose it in community recruited women, healthy women? Are we going to try and diagnose it in women with an ovulatory disturbance, or women with hyperandrogenism, or women with polycystic ovarian morphology? All these make a difference on how AMH performs as a diagnostic test. So we've had diagnostic parameters for PCOS that have changed over the years. We started in the 90s with the NIH, which really emphasized the importance of ovulatory disturbance and hyperandrogenism. And then, of course, that was replaced in 2004 by the Rotterdam Consensus, which really put ultrasound very much on the map. And of course, that widened and captured more women into the diagnostic criteria for polycystic ovarian syndrome. And then lastly, the Hyperandrogenism Society have really reiterated the importance of hyperandrogenism as the diagnostic criterion. But this has been a moving feast over the years, and we know that it's all tied up with a whole lot of complex metabolic consequences, endometrial cancer, sleep apnea, mood disturbance, and so on. And of course, also we know that the different diagnostic criteria allowed us to have different phenotypes. And initially we had the classic phenotype, which had all three features from the Rotterdam Consensus, the ovulatory PCOS phenotype, which was just hyperandrogenism and polycystic ovarian morphology. And then the third one was the normoandrogenic, but who were ovulatory but met were anovulatory and met the criteria of PCOM. So that's actually a typo then. So there were three phenotypes initially, but then it got even more confusing over time because type 1 was divided into A and B according to whether they had polycystic ovarian morphology, and I'll talk a little bit more about that in a moment, or not having polycystic ovarian morphology. So in summary, our phenotype 1, classic, turned into A and B, which were called complete and classic, rather confusingly, and the ovulatory PCOS phenotype became type C, and D was the normoandrogenic but anovulatory phenotype, phenotype D. So when we're doing a diagnostic test, we have to use that, test it against our gold standard. And our gold standard here is a little nebulous, and a little bit more about that. And I just want to take you, first of all, through the population, the population studied. And this is nicely illustrated in the phenotypes. And this data is about looking at the four phenotypes. If you recruit from the community, you can see that they're pretty well equally distributed, 1, 2, 3, A, B, C, and D. But if you actually look at a referred population in a hospital, those that we tend to work with and are much easier to study, then you can see there's very much a greater overrepresentation of complete PCOS. Those who have the full house phenotype A is nearly half the cases. So the population studied for our gold standard is really important. The other thing that's changed over time is that ultrasound has become have of higher resolution. So that the criteria of the Rotterdam consensus, 12 follicles, the ovarian volume of 10 mils remains the same. But if we use the follicle number per ovary as 12, we found over time, and this is very elegantly recorded in this study, that as the probe transducer increased and the resolution of the probe increased, and that happened with time, more women were meeting the threshold of 12 follicles per ovary. And in fact, this paper proposed, and it's been largely accepted, that the follicle number per ovary for polycystic ovarian morphology should be greater than 25 follicles per whole ovary, where a probe transducer greater than 8 megahertz is used, and they're very infrequent use. So again, in our literature, we can see that our gold standard for diagnosis has changed over time, and that makes it very difficult. To muddy the waters further, we have the anti-Müllerian hormone, the AMH hormone assay, has had a checkered past. And I refer to this recent review as an excellent summary of the problems that we've had with AMH. There is considerable inter-assay bias between the three main proponents, and in fact, World Health Organization has a reference reagent, not a reference standard for AMH, because of the difficulties in standardizing the assay. We know that AMH exists in isoforms. It's secreted as a prohormone, it's cleaved, and it has disulfide bridges. It's then glycosylated, and the different isoforms are captured by the different antibodies in the assays, and they may, of course, not relate to the activity of the AMH physiologically. And of course, we've had different antibodies in the different assays over time, and many of you will remember the issue with the effect of complement on lowering the AMH level in fresh samples. And we still have an ongoing problem with analytical interference with biotin. In addition, there's been a limit of detection variable between the different assays. Some are better at a lower level and some are better at higher level, and that's very common in endocrine assays. And there is a high systematic error between the different assays. So the AMH is not an easy assay, again, to use. But let's look at what studies are out there that look at AMH as being a diagnostic test for PCOS with those limitations that I've articulated here. There is a meta-analysis from 2013, and these are in symptomatic women with PCOS. So that population definition is important, had a sensitivity of 82% and a specificity of 79% if there was a cutoff of 33.6 picomoles for the AMH level. Nothing about the age. And I think that's actually one of the things that's not reflected in any of the studies, is that one would imagine that there should be an age-based threshold, but these meta-analyses are just universal. So setting up at 33 picomoles. And that's in symptomatic women. If we look at more recently, asymptomatic women with polycystic ovarian morphology versus asymptomatic women with a normal ultrasound, and looking at their AMH to see if AMH is a replacement for the polycystic ovarian morphology. And that had a sensitivity of 92%. It was higher than the antral follicle count, and a specificity of 97% versus 92%. So it's looking pretty good, with the threshold being 35 picomoles per litre against antral follicle count. So that's encouraging in asymptomatic women. There is the Aphrodite study, which was published last year from Jude Lavin's group. And this study used the Rotterdam consensus for the diagnosis of PCOS versus control women, and looking at polycystic ovarian morphology using the older criteria versus AMH. And with the Roche Alexis, the cutoff appeared to be about 23 picomoles per deciliter. So you can see it's a little difficult to be sure if AMH is a useful test. What is the ideal study? Well, it probably is community recruited women who have a high resolution ultrasound, setting the threshold for the diagnosis of polycystic ovarian morphology at 10 mils or greater than 25 follicles per ovary. And a good androgen assay. I haven't talked about the problems with androgen assays, so that would be liquid chromatography with mass spec, and standard handling of the AMH assay. And last month, from the Australian group in Melbourne, this was reported. And what they did is they used two assays, the Beckman-Coulter Generation 2 and the Anch-Menosh. And they looked at community recruited women, those with and without polycystic ovarian morphology. And how well did these AMH assays perform in this setting? Well, if you set for the Anch assay, the AMH at greater than 44, which seemed to be the right level. Oh dear, so I've got one. You can see, and I just need to take this away. You might be able to see better than I, because I've just had a drop down here, go away. You can see that the sensitivity was, and that positive predictive value and negative predictive value are there. And if you set it at 33 for the Beckman-Coulter assay, you can see the positive predictive value and negative predictive values. But out of the population that was studied, there was an extra 6 in the Anch assay and an extra 8 women out of 70 who were captured into the diagnosis of polycystic ovarian syndrome by using the AMH assay. And 1 was missed by the Anch assay and 2 were missed by the Beckman. And that's out of 70. So you can see there are problems here, because both assays increased the diagnosis in 6 women of 163 being diagnosed with PCOS. And that kind of inaccuracy may not be acceptable to us in the community. Here you can see there's pretty nice, this is looking at the AMH levels for the Anch assay and the Beckman assay, and you can see that if they don't have polycystic ovarian syndrome, the AMH is lower, and if they do, it's higher, and there's a reasonable amount of cutoff there. So there is progress. So what would I say in answer to this question? Yes, probably, not yet, but possibly in the future. There is possibility that AMH will replace PCOM as one of the alternative diagnostic criteria for polycystic ovarian syndrome, but we're not there yet. Does AMH predict the response to treatment? Well, what do we know? Women who are less likely to respond to ovulation induction have a higher AMH, and that's been recently confirmed in another group where the higher AMH predicted a failure to ovulate with letrozole and clomiphene, though not so much with FSH. We also know that when women undertake IVF, if they have a higher AMH, they have a lower fertilization rate and a lower live birth rate from the fresh transfers, but not a lower live birth rate from cumulative. And so it's probably an effect of the high estrogen and androgens on the endometrium during their fully stimulated cycle, because it doesn't seem to be there in frozen. So I think AMH probably does predict response to certain treatments, ovulation induction and potentially IVF. Does AMH tell us anything about pathogenesis in PCOS? Let's look at the work there. We know that there's a stagnation of follicular development from transitional and classic primary follicles in PCOS, and that seems to be have the consequence of a higher AMH, and that's quite old data. We also know, very interestingly, that there's a higher production of AMH per follicle in women with polycystic ovarian syndrome. So it's 4-fold elevated in women with PCOS and 75-fold elevated in anovulatory women who have PCOS. We also see that AMH is higher in anovulatory women as opposed to ovulatory women. And we also know that AMH may inhibit the action of FSH to stimulate ovulation. So, and I've alluded to the fact that there is this little drop in AMH around the time of the FSH and LH surge in ovulation. In addition, we know from a Chinese cohort recently that of women who had obesity and PCOS, the insulin resistance was more severe if their AMH was elevated. And indeed, in this, AMH also seemed to stimulate pancreatic insulin release in a mouse model. In addition, AMH is also thought to increase LH pulsatility and secretion. So whilst we don't really have a clear picture of pathogenesis of polycystic ovarian syndrome, AMH does seem to be tangled up in it and may in fact be a driver for the polycystic ovarian process. So does AMH change with the treatment of PCOS? What's the evidence here? Well, from Australia, we have that overweight and obese women with PCOS who lost weight had lower AMH levels after their weight loss. We know that laparoscopic ovarian drilling, which is associated with a return of ovulation, is also associated with a drop in AMH. We also know that exercise in polycystic ovarian syndrome is associated with a reduction in the AMH. So I think the answer to this question would be yes, treatment of PCOS does change the AMH level. The last question I want to turn to is, does AMH predict metabolic syndrome or phenotype of PCOS? And I've alluded to the difficulties with our gold standard here for phenotypes, that it changed over time, and now 4 phenotypes, and I've talked a little bit about that. The studies here are quite conflicting, and I think they vary according to the population studied, the ethnicity studied, and the methodology and the definitions of the phenotypes. So some studies would suggest that AMH is higher in hyperandrogenic PCOS, the phenotypes A and B, and also that their higher AMH may be associated with high LH and more severe features. But conversely, there is data coming from other studies in China, for instance, that high AMH is associated with less hyperinsulinism or is associated with lower total body fat. So I think the answer to this question is that it's uncertain that AMH predicts metabolic syndrome or phenotype. So why is this such a mess? And this is my last slide. I think I've alluded and shown that the AMH assay over time has varied and it hasn't always performed well. And of course, that has been incorporated into the literature over time. So the historical literature may be less reliable. We also have different populations selected in our literature to define PCOS, community-based, those having medical treatment, different countries, and also adolescents who transiently meet the diagnostic criteria for polycystic ovarian syndrome. We've also had changes in the resolution of ultrasound over time. We've used different androgen assays. Some have had poor sensitivity and poor precision, and we really don't have good standards still now. I think AMH probably will become a diagnostic test for PCOS and may be, in fact, an alternative to polycystic ovarian morphology. But AMH, we know, is involved in the pathogenesis and it may predict the response to treatment, and it falls with the treatment of PCOS. But the place of AMH in the discrimination of phenotypes is uncertain. So I hope that's given you some food for thought, and hopefully it will stimulate some questions. Thank you very much for asking me to speak to this topic.
Thanks a lot, Madam, for your extraordinary and brilliant talk. Now I am requesting Professor Kohinoor Begum, Madam, to introduce our third speaker. Madam, please.
So thank you for very nice presentation. Our third speaker is Professor Virgilio Novero. He is Associate Professor of University of Philippine College of Medicine and General Hospital. He is the past President of Philippine Society of Reproductive Medicine, current Treasurer of Board of Aspire. He is the board member of Asian Society of Fertility Research and now head of the Center of ART and Infertility at St. Luke Medical Center, Global City. So I am requesting Professor Dr. Virgilio to give his presentation. Thank you.
Thank you for the kind introduction. May I share my screen, please?
No, but you are the vice. Correct your designation of Aspire.
Okay, here we go. Thank you for the invitation, especially to Professor Maroof, who invited me over for I think this is my third talk in a Bangladesh event this year. The talk that I'm been assigned to give is the clinical utility of serum AMH determination in reproductive medicine. This is a review. After having heard my colleagues in Aspire, Professor Wiweko and Dr. Boothroyd, I feel that there might be some overlap, but I would still like to go around these overlaps because I think we could still learn a few things. In fact, the first two lectures would already be some forms of clinical utility of serum AMH in reproductive medicine. So I have no conflict of interest for this talk, and my objectives are just to review the clinical uses of serum AMH determination in reproductive medicine and highlight the recently proposed practical uses of AMH. And these would be my outline. So AMH is a dimeric glycoprotein first seen in the 50s, responsible initially assigned for the regression of the Mullerian ducts in male fetuses. And its potential uses in women were first reported in 1986 as an endocrine marker of ovarian response after disappointments with FSH, inhibin B, and AFC and other tests. But today, it is considered one of the most reliable biomarkers to predict ovarian reserve response, considering all the false tests about it. Now, in men, AMH is secreted by the immature Sertoli cells, and as mentioned, regression of the Mullerian ducts in male fetuses. But in women, it is produced by the granulosa cells in the preantral and small antral follicles. And participates as an inhibitor of the recruitment of oocytes in the germinal vesicle stage. But in all, serum AMH levels from women are far lower than those in men throughout life. This is a nomogram of the course of AMH throughout life from birth to menopause. At birth, AMH is very low, and there's a subtle increase at ages 2 to 4, increases in puberty, but really peaks at ages 15 to 20. Beyond 25, it now begins to decline until being undetected after menopause. And this figure has already been shown by Claire, but to focus that the action of AMH in the ovary is really to inhibit AMH on follicle of FSH-induced CYP19A1 expression, leading to reduced estradiol levels and the inhibitory effect of E2 itself on AMH expression. So with all these in mind, let's just breeze through the different properties and factors affecting the levels of AMH. As mentioned, this again is a review. AMH does decrease with age, as we've shown earlier. This trend is similar to AFC, but inverse to follicle-stimulating hormone. And this decrease happens before any sign of menopause can be seen, where it only becomes undetected during menopause. So when you discover the reduced serum AMH concentrations, it may indicate ovarian aging. Again, as mentioned previously, it is the same throughout the menstrual cycle, and within the same cycle or between different menstrual cycles. There are a few reports that AMH may have variations, but it is not large enough to cause a change in current practice. Yes, there are ethnical variations, and this we have to emphasize. It is lower in African Americans with more undetected AMH levels, where the women were still menstruating monthly. And in Asians, there are similar AMH levels to Caucasians. However, they have decreased AFC and lower yield of oocytes during IVF compared to Caucasians. So this suggests a decreased response to ovarian stimulation. It is lower among smokers, suggesting an altered metabolic pathway, including estradiol. And there are a few conflicting reports whereby smoking seems not to contribute to this decrease, but rather the other confounding factors such as age and ethnicity. Definitely, it is lower after gonadotropin stimulation. The levels of your AMH drop during COS upon using FSH injections. This could be an effect of a direct or indirect negative influence of FSH on AMH. Remember, in the mechanism in a couple of slides earlier, we showed that FSH increases estradiol, which could be the reason for AMH to decrease, because estradiol negatively influences the regulation of mRNA for ovarian AMH. So it is not valid to do AMH sampling during controlled ovarian stimulation. There are studies which point to the fact that there is a positive correlation with vitamin D, although others did not find that correlation. It might be related to the presence of a binding complex for vitamin D in the promoter of the AMH gene. Quite recently, Aramesh showed that among 51 women with decreased ovarian reserve, if you supplement higher doses of vitamin D, there will be a significant increase in your AMH. There might be a correlation, negative correlation with BMI. This is mentioned only as apparent because there are those who contradict this. There are reports of obese women with lower AMH compared to normal weight group. And there is poorer effectiveness of IVF among obese women contributing to this concept. Again, there are conflicting reports because in other studies, AMH is not correlated to BMI, but rather it is age dependent. In our own study last year, we showed that BMI has a minimal effect on AMH over time. And there are levels of AMH is higher among women with PCOS. Dr. Claire already showed that. High levels are 2 to 3 or 2 to 4 times higher among women with PCOS compared to healthy ones with normal ovulation. There are more studies that suggest that the diagnosis of PCOS should be replaced by the measurement of AMH, and the suggested levels of 4.7 was already mentioned. Our own study in the Philippines puts our cutoff to be at around 3.86. So the elevation of AMH in these women is linked to a larger number of preantral and antral follicles, but also the increase in the per cell secretion of AMH. Levels are lower among those taking oral contraceptives, and this reduction is about 13 to 20%. This is because of a period of ovarian quiescence and a suppressive effect of hormone contraception on AMH, and its predictive capacity for ovarian reserve is affected. So it is more pronounced also in those taking the pill for a longer period of time. And levels are lower among pregnant women, with the decrease especially noted in the second and third trimesters compared to the first trimester, the drop being about 50% at the end of pregnancy, again, attributed to ovarian quiescence and reduced follicular maturation. Now, proceeding to the different uses of serum AMH, there are uses in both obstetrics and gynecology and cancer, gynecologic cancer and pediatrics. But because this is on reproductive medicine, we will only be focusing on these smaller issues. So as regards to ovarian reserve, this was already shown as an example in the talk of Budi Wiweko, where it is now the premier biomarker for female fertility. It decreases with age and undetectable after menopause, and the reference ranges need to be established at 25th to the 75th centiles expressed in nanograms per ml or mmol per liter. In the Philippines, we've had our recent study of our own nomograms last year. The reason for AMH, the basis for making your nomograms is because of folliculogenesis. Earlier in our career as doctors, we were only taught about the folliculogenesis part of antral follicles maturing to your preovulatory follicles over 14 days. But later, we did find out that the progression of folliculogenesis takes approximately longer, even 9 to 10 months, whereby the progression from your primordial follicles takes about 5 months, and from your primary follicles to preantral follicles, another 3 or 4 months. So in reality, with knowing all of this, you really would like to know what is the true ovarian reserve, which is an indication of your primordial follicles, but your AMH only measures those in your preantral and your antral follicles. So AMH only really is a surrogate ovarian reserve marker, not the true ovarian reserve marker. Again, showing the different nomogram studies around the world, where there's those in the West and also many here in Asia, the mean AMH levels are really varied, although they're quite similar, somewhere between levels 2 to 4 in nanograms per ml. But again, shows the different ethnicity variations of serum AMH levels. Now, where is AMH unreliable as a biomarker of ovarian reserve? One is in hypothalamic amenorrhea because you have your low AMH and no follicles are entering your FSH-dependent portion. We already talked about PCOS where AMH is elevated and there is follicular excess and increased AMH. And we also talked about conditions where AMH is decreased because of its quiescence. These include those who use in oral contraceptives, pregnancy, and long-term GnRH agonists use. Now, an additional use in ovarian reserve testing are those in women with BRCA positive carriers, where they've shown that there are lower levels of AMH in BRCA carriers where the decrease is about 20% lower than your AMH with those with mutations compared to those who don't have them. So this helps us in treatment planning for these women with BRCA. It also can be used as a tool to diagnose PCOS. This was already adequately discussed by Claire, so we will not go into further detail about this. So there is controversy whether to use a single value and adding it to the Rotterdam criteria. And we already explained why AMH secretion is higher in polycystic ovary. But again, just to show you the different cutoff levels to predict PCOS in many studies existing, levels from as low as 3.4 to as high as 7.3, again, suggesting varied ethnicity findings as regards to predicting PCOS. So as a predictor of PCOS, there are points for and against it, and these were tackled in depth by Claire. It is best in complicated PCOS, but again, it is still uncertain because of this 2 to 4-fold increase in levels of your AMH. However, when you add AMH in your Rotterdam criteria, sensitivity and specificity seems to increase to 89 to 100%. But the points against really is about the variations in AMH levels with ethnicity, analytical methods. Again, you have to be using the most recent, which are your automated AMH systems as compared to your manual systems to have more consistency in your results. And we do not have a validated universal cutoff value so it's still a problem, and we can't use this for now. That's why we can't use it definitively as a PCOS predictor. This is widely known, AMH as a predictor of ovarian response. There's a strong correlation of AMH in the number of retrieved oocytes, and this is a better prognostic marker than age, day 2 to 3 AMH, and the level of estradiol. And as I mentioned, AMH is strongly positively correlated with your AMH. Just to bring back the gold standard or the landmark study of Sonkara in 2011, where they predicted that the most ideal situation is to harvest 8 to 15 eggs, because if you harvest more, you're at higher risk for OHSS and lower live birth rate, and the opposite for if you get lower numbers of oocytes. So to get individualized results to reach 8 to 15, you must individualize your treatment. And one of the ways to do it is to really use AMH, a well-studied AMH level for your patients to minimize cycle cancellation and eliminate iatrogenic risk such as your OHSS. To predict poor response, it is good. The AUC, the area under the curve, would be 0.78. For excessive response, it's even better, 0.81. And however, the thresholds to predict poor response vary again according to the population. Depending on the population, you'll have variations from as low as 0.2 to 1.8 in different populations. This is in nanograms per ml. And also to predict excessive response, variations from 1.5 to 4.8. So a lot has to be done in measuring AMH according to the different population groups. But nonetheless, the point is to individualize AMH-tailored ovarian stimulation. And the most recent example that we have for this is having used such in the study of polytropin delta compared to the conventional dosing. These are the Asian data provided by Professor Kiao very recently, where following on the different AMH levels and correlating it with BMI, they were able to show that there will be less OHSS and higher birth rates if you would be basing your ovarian stimulation on AMH levels. So AMH seems to be the most reliable biomarker for ovarian reserve, and along with it is AFC, but there are discordancies between AMH and AFC in predicting ovarian response. The discordance has been estimated to be about 26 to 30%, and the suggestion is when this happens, especially if they belong to different quartiles, is to give an intermediate dose if levels belong to different quartiles. Finally, our last clinical utility will be its use in patients undergoing fertility preservation, where AMH is among the first tests that you will be using in choosing patients for fertility preservation. It will also serve as sure guide in gonadotoxic effects of cancer therapy, and it is important in post-cancer therapy assessment of fertility. Just a couple of studies regarding AMH uses again in oncofertility. They've shown that the levels of AMH in cancer patients, even before chemotherapy, are lower compared to those even before chemotherapy. And so the drop is also another thing. There is the drop may also be dependent on the type of cancer and the type of treatment being given in the cancer. In this other study by Kui in childhood cancer survivors, there are variations of AMH over time, but they've shown that this decline in, there's no decline or no accelerated ovarian function loss in patients with childhood cancer. So let it be said that there appears to be no acceleration of ovarian function loss in patients with cancer. Now, the last that I'd like to mention is the prediction of pregnancy or live birth, which is one among the first studies that was tackled very early, about a decade earlier, which showed that AMH might be predictive of a good response or a good outcome. However, in the meta-analysis shown study of Brewer, that the area under the curve for predicting ovarian outcome is quite poor. The AMH area under the curve is below 0.6, it's only 0.55. So it is not shown to be a good predictor of successful IVF outcome. That was my last slide. So in summary, anti-Mullerian hormone measurement has emerged as a very useful biomarker in reproductive medicine. And it is key in as a useful tool in estimating ovarian reserve, predicting excessive and poor response, and as an adjunct in diagnosing PCOS, and as a guide in fertility preservation management, but not to help predict IVF outcome in fresh cycles. Thank you very much.
Thank you, sir, for your excellent and evidence-based presentation. Now is the session and time for our chairperson remarks. First of all, I would like to hear something from our legendary Professor Kohinoor Begum Madam about the first speaker. Madam, please.
Madam, unmute করে নেন। Kohinoor Madam, unmute করে নেন।
Thank you, Dr. Jaya. Premature ovarian failure or insufficiency, it means that it occurs before age of 40. So there is a difference between the premature ovarian insufficiency and premature menopause. In case of premature menopause, the period stops before 40, but she has no longer a chance of pregnancy, or it may be natural occurring or maybe disease process. But in case of premature ovarian insufficiency, the period stops before 40, but she may get pregnant, because in most cases, there is some infrequent ovulation in case of premature ovarian insufficiency. So incidence, if we consider incidence of premature ovarian insufficiency around the age of 40, it is 1 in 100 women, but it can occur a bit earlier. At the age of 20, the incidence is 1 in 1,000 women. If we consider causes, we can divide it like the spontaneous. If the cause is spontaneous, it may be idiopathic or genetic, or it may be autoimmune or infectious. And if it was induced, it may be bilateral oophorectomy, chemotherapy, radiation, environmental toxin. So who are the risks? Who are the risks for developing POI? The family history, there may be family history, there may be genetic, there's certain disease like autoimmune infection and viral infection, the cancer treatment like chemotherapy or radiotherapy. And these ladies present to us with first signs of POD like irregular menstruation or later symptoms like the normal menopause, later menopause. But there may be some complications also, like anxiety, depression, dry eye syndrome, heart disease, infertility, low thyroid function, and osteoporosis. So diagnosis, we have diagnosis by history, physical examinations, investigations. We can do it by, and how we can minimize the complications. Generally, these patients need very good counseling because they become psychological, they become upset, so they need very good counseling. Then hormone replacement therapy, because to prevent these complications, she needs hormone replacement therapy until the age of natural menopause. Calcium supplementation and vitamin D, she might, as the first speaker says, she needs some of the enzymatic treatment like Q10 or DEAC. If she consider, if she is obese, physical activity and healthy weight gain, and treatment of condition associated with POE. And last of all, if she wants pregnancy, she will have to go for IVF treatment. So in conclusion, we can say, though the etiology is not very good, she had some long-term and short-term complications and some physical unwell. So while awaiting the blossoming of a promise, the tissue-specific stem cell salvage and therapy may offer, timely initiation of hormone multidisciplinary approach must be recognized the cornerstone to effectively manage this complex entity to ensure that physical, psychological, and emotional challenges that result from POI diagnosis are met and short-term, long-term complications of the young girl is optimized. Thank you, Joya.
Thank you, Madam, for your excellent talking. Now I am requesting our second chairperson, Professor Farhana Dawan, Madam. Madam, would you please say something about our second and third speaker?
Thank you, Professor Dr. Joyashree Shah. Actually, the presentations were very interesting and very informative. Regarding the presentation of Professor Claire Bothroyd, she talked about the place of AMH and in diagnosis of PCO, and she highlighted on the replacement of talking about the Rotterdam criteria for diagnosis of PCOS and how it has evolved regarding the high resolution of ultrasonography, and now whether there's thinking about changing the criteria from 12 follicles to 20, more than 20 follicles. And then she had mentioned that although high AMH may be a marker of PCO, but there are some uncertainty of the assays available and there are some difficulties. And she has gone about talking about the current two assays which are promising, that is the Beckman counter assay and the ANSH. And now, very interestingly, she has gone further to in her presentation by answering 5 questions. The first question was, can AMH be used as a diagnostic test for PCO? She has talked about the PCOS phenotypes, the classic ovulatory and normoandrogenic, and she's talked about the difficulties in standardization, differences antibody difficult assays. And lastly, she has mentioned that it may be a possibility in the future. The second question she put up was what about the response to treatment? Does AMH respond to treatment? And then the answer was yes. And the third question was, does AMH tell us anything about the pathogenesis of PCOS? After some studies, mentioning some studies, also the answer was yes. And the fourth question was, does AMH change with treatment of PCOS? And she has mentioned that yes, after the studies, it has been proved that treatment of PCOS does change with AMH level. And her last question was, does AMH predict the metabolic syndrome or phenotype? And she has given the detail of 2 conflicting studies. Some studies say yes, giving the highest level of AMH, and some studies had different value, different opinion. So in summary, she mentioned that AMH assay varies, and because of the changes in resolution of ultrasonography, but AMH will be a diagnostic test for PCOS in the future. And the third speaker, Dr. Virgilio M. Novera, he has also very nicely stated the clinical utility of serum AMH determination. And he has mentioned the properties of serum AMH that help in identifying the usefulness. And he has mentioned that although AMH decreases with age, but is constant throughout the menstrual cycle and in between the different cycles. And he has mentioned about the tool to diagnose PCOS. That is, it is a tool. It helps to diagnose PCOS, especially in certain subsets. An increased AMH level in PCOS not only is a product of more follicle, but it also is up to 75 times higher in secretion per granulosa cells. And he has also mentioned about some controversies and about the it is a tool in assessing the patient undergoing fertility preservation and AMH determination in oncofertility. So he has also concluded by saying that AMH is very useful marker in reproductive medicine. Thank you very much for giving me the opportunity to give the comment. Thank you so much.
Thanks a lot, madam, for your valuable remarks. Now it's the time for question answer session. For the time constraint, dear audience, we have just take 2 questions. First question to Professor Claire. Dear madam, can you solve this problem? I ask you the question first. Madam, a patient 25 years old presents with infrequent menstruation and primary fertility for last 5 years. Her TSH, prolactin, glucose tolerance test, all are within normal limit. Semen analysis also within normal range. Her AMH was 10 nanogram per ml and ovaries had multiple antral follicle. She was under the treatment by letrozole 10 milligram per day. On folliculometry, there is different cycle. Largest follicle was 12 millimeter. Madam, what is the significance of this high anti-Mullerian hormone level?
I think, did I miss that she had an ultrasound? She's actually an ovulatory and a normal prolactin. And I think the AMH in SI units is about 70 picomoles roughly, isn't it? And did she have an ultrasound, Joyshri?
Yes, madam, she had ultrasound, and ultrasound revealed ovaries had multiple antral follicle, and her AMH was 10 nanogram per ml.
Yeah, so we have got ovarian volumes, you know, because that's going to be a good, you know, and we need to know about what kind of probe was used, and to see if she does meet the Rotterdam consensus. And we, of course, haven't got androgen assays, and of course they're expensive assays. And but of course you can use in low or medium resource settings, you can use the clinical parameter of hyperandrogenism. So I don't know if we've got any information about that. Those would be the sort of things that I'd be wanting. And let's assume that they are present. Then we're embarking on ovulation induction. And I think you implied that 10 milligrams of letrozole gave a 12 millimeter follicle and presumably no ovulation. I mean, I think there are a number of ways to do this, but I tend to use 2 cycles of letrozole. And then if that's not effective, I move to clomiphene, 2 cycles of clomiphene. And if that's not effective, I actually add in metformin and clomiphene. I think the metformin letrozole combination hasn't been terribly well researched, so I don't tend to use that. But then after 6 cycles, then it becomes the next decision tree really is, do we go down laparoscopic ovarian drilling? And she's likely to do very well from that. Or FSH, ovulation induction. And again, that's a personal choice and a resource setting choice. And I personally think that laparoscopic ovarian drilling is in a low and medium resource setting is a highly effective way of stimulating ovulation in a lady such as this. And of course, it's associated with no twins, which is also, where she may or may not have access to neonatal nursery facilities and so on, may be a desirable outcome. So I hope that's answered that question adequately. But thank you very much for the question.
Thank you, madam. Now I want to ask a question for Dr. Virgilio Novero. Sir, can you hear me, sir?
Yes, I can.
Yes.
Go ahead, please.
Sir, a 26 years old lady, married for last 1 year, present with the history of infrequent menstruation for the last 6 months, with irritability and repeated hot flush for several times in a day. What's the prospect of fertility for this patient?
Well, we need to evaluate them first. The information you told me so far was clinical. I am not sure, because she has hot flushes. Are you suggesting that she has low estradiol secretion? That she going into premature menopause? I think we need to evaluate her completely by laboratory tests and also by ultrasound, so we can decide how to approach her. If she has POI, then we approach her to the direction of the talk of Professor Wiweko. And if she's polycystic ovary, then we direct her to the direction of the talk of Claire.
Thank you, sir. Dear audience, as we are lagging behind of time, now we have to hand over the microphone to our rapporteur to conclude the session. Dr. Umme Salma, please conclude the session.
Thank you, Dr. Jastri Shaha, for wonderful moderation. So, respected participants, we have enjoyed 3 excellent talks from 3 of the most renowned academicians in this field. We have also listened from 2 honorable chairpersons. It's my proud privilege to be the reporter of this prestigious session. Our heartfelt thanks to the honorable chairpersons, eminent speaker, moderator, and the participants. This session has come to be an end. Now it's time for a commercial video by Popular Pharmaceuticals, who sponsored this session. Thank you very much for staying with us.
Moderator King.
Learned audience from home and abroad, I'm Dr. Pushpita Sharmin. Assalamu alaikum. I'm working as medical officer at NICDU. I'm rapporteur of this session 3. Welcome you all to this very important session of 6th International Scientific Conference organized by Fertility Sterility Society of Bangladesh. We have 3 eminent speakers from abroad. We are honored to have Chairperson National Professor Shahla Khatun ma'am. She is the former president OGSB Society and former head of Bangladesh Medical College and Hospital. She is current president of Bangladesh Menopausal Society. Professor Shahla Khatun madam, we are very honored to have you in this session. We have another chairperson, Professor Saria Tasnim madam, Principal and Head of Department of OBGYN Community Medical College. We are also very much privileged to have Professor Saria Tasnim madam in this session. The session will be sponsored by Renata Limited. Now, I'm welcoming moderator Dr. Nargis Fatima, Senior Consultant OBGYN Department, Square Hospital. To moderate the session, Dr. Nargis Fatima, I'm welcoming you to conduct the session.
Thank you, Dr. Pushpita. Assalamu alaikum. Assalamu alaikum and very good afternoon to my respected teachers, my mentors and the learned audience. With the permission of the chairs, I would like to invite the first speaker of this session, Professor Rishikesh Pai. He would be talking on the fertility preservation, the current perspective. Professor Rishikesh Pai is the medical director of Bloom IVF Group. He's the president-elect FOXY. He's the director of corporate affairs, IFFS. He's the past president of ISAR, IAGE, MFS, and MSR. And he is awarded with more than 50 awards, including the prestigious Lifetime Achievement Award of ISSRF in 2019 and ISAR in 2020. He is editor of over 16 books and written more than 50 chapters. Professor Rishikesh Pai, sir, over to you.
Just share my screen. Can you see the screen, madam?
Yes, sir.
Thank you. I would like to thank the Fertility Sterility Society of Bangladesh, Professor T.A. Chowdhury, Dr. Maruf Siddiqui, and my chair, Shaila Khatun, Saira Tasnim, and Nargis Fatima, for allowing me to present my views on fertility preservation. As the FOXY president in 20 to 24, I'll be taking over as the president of the federation. My topic, theme of my conference is modern technologies transforming life, and fertility preservation is one of these technologies. If you look at historically at the technologies of fertility preservation, you can see that it was the ethics committee in 2005 of the ASRM which started looking at this technique, and then the American Society of Clinical Oncology was looking at it in 2006, and it was actually in 2013 when the ethics committee of the ASRM started defining it more precisely, and the H3 guideline came out in 2020, and it really allowed fertility preservation for clinical application. If you look at the indications of fertility preservation, one of the main indications is oncofertility. It is called OncoFP, and mainly the indications are for prior to breast cancer therapy, for hematological cancers such as Hodgkin's and non-Hodgkin's lymphoma, and other cancers, genital cancers. You can as well do fertility preservation. You can also do fertility preservation prior to endometriosis surgery. It is called endofertility preservation. And then we can do fertility preservation for lifestyle purpose, and that's called elective fertility preservation. In oncofertility, you need to do it prior to chemo or radiation therapy, sometimes in radical surgeries like vaginal cystectomy, bilateral oophorectomy for other purposes, and prophylactic oophorectomy, especially in women with past history of or a family history of breast cancer having positive BRCA1 and 2 genes. You can do fertility preservation prior to oophorectomy. There are various methods of fertility preservation. One of the commonest is the oocyte cryopreservation, also called OC. Then we have the ovarian tissue cryopreservation, which is called OTC. And after you preserve it, when you transplant it back, it is known as OTT, ovarian tissue transfer. And then sometimes women are married and they have cancer and they have a husband, they would like to do embryo freezing rather than oocyte freezing. And there are three experimental techniques such as in vitro growth, in vitro maturation, and isolation preservation of stem cells and artificial ovary, which are still in the experimental phase. If you look at this lovely diagram by Dolmans and Fertility Study in 2021, so there are two methods mainly. You preserve the oocyte, especially in post-pubertal patients who want to undergo chemotherapy. You have a time period of 2 weeks at your disposal. And in age-related fertility decline, who want to preserve their eggs, as I told you before, you can vitrify them and later on thaw them, create the embryos and transfer them back. And in patients, pre-pubertal patients, who need immediate chemotherapy, there is no time for you to actually take the oocytes out, no time for gonadotropin stimulation, and they require immediate chemoradiation therapy. You can take the ovarian tissue out, freeze it, and after she gets okay again, you can look at the assess the risk of malignant cell metastasis into the frozen tissue. If the risk is low, you can retransplant the tissue back into the ovarian fossa, and if the risk is high, you can in the future isolate the follicles, do in vitro maturation, create artificial ovary, and transplant the ovary back into the patient. So in the fertility preservation, there are three combination strategies. You can do oocyte cryopreservation, or you can combine a oocyte cryopreservation with the ovarian tissue cryopreservation, or you can do ovarian tissue cryopreservation. So these are the three options. And we look at the risk of the chemotherapy. If the chemotherapy is intense, there's a high risk chemotherapy. If the patient is exposed to chemotherapeutic agents like cyclophosphamide or programmacil, or then you would go for definitive therapy. While there are low risk chemotherapies like methotrexate, 5-fluorouracil, where the risk of destruction of the ovary is not that intense. Then you also can look at the radiation risk, and you can see here that if there is an exposure of 2 guys, then 50% of the ovary is lost. And if there is more than 5 guys, nearly 70% of ovary is lost. So based on the guy exposure to the patient in radiation therapy, you can predict whether this patient is going to go for a total ovarian loss. You should also look at the metastasis risk, because ovarian metastasis is important to understand. If patient has a high risk of ovarian metastasis, you freeze the ovarian tissue. After 5 years, when you re-implant the tissue, you may re-implant the cancer back. And that's why you look at the low risk patients, especially breast cancer stage 1 and 2 disease. This is the most common type for which we do fertility preservation, or Hodgkin's lymphoma are two important diseases for which majority of the time we do fertility preservation, because the risk of metastasis is very low. So this is a time frame chart, and if there is a favorable prognosis and the future pregnancy is compatible with patient's health, there is a high risk of infertility following the treatment, and there is a chance to preserve the fertility, then based on the time frame available to us, if there is a time frame of starting the chemo radiation is less than 1 week, you would go for just a GnRH agonist treatment, or you can go for a ovarian tissue freezing immediately. But if there is more than 2 weeks time frame, you can do ovarian stimulation and you can go for oocyte freezing. What about the protocol? So the antagonist protocol is the commonest protocol nowadays used, and immediate random start protocol is the one which we use very often. That is, you start the stimulation as soon as the patient comes to you. You don't wait for the stimulation to occur. For example, if there is a patient who comes in the early phase, you look at the scan, the follicle is less than 12 millimeters, you can go straight for gonadotropin stimulation. And if the breast cancer receptive positive is there, you add letrozole 5 milligram from the day 2 of the gonadotropin stimulation, and you add the antagonist when the leading follicle is 14 millimeters, and then you give a trigger with GnRH agonist trigger. So if on the other hand, if the patient comes in the mid follicular phase, again you look at the scan. If the follicle is more than 14, you will give a GnRH trigger to bring about a rupture of the follicle and then start the stimulation. So this is known as random start stimulation. And there are a lot of studies that are shown here. This is a big study that has come, 19 studies over a 7-year period, that the random start stimulation was associated with a shorter interval between ovarian stimulation and oocyte retrieval, although higher gonadotropin dosage was required, while the yield of mature oocytes and cryopreserved embryos was comparable with conventional stimulation protocol. So this is very important, and this is the summary of the whole stimulation protocol. If a patient comes to you, you do the consultation. If there is not enough time, next day you can do a laparoscopy and do a hemioophorectomy. And if suppose there are 2 weeks available to you, you can start the ovarian stimulation. We're using the random start protocol. If there's a breast cancer with the estrogen receptor positive, you will add a letrozole to it. Once the leading follicle is more than 14, you will start the antagonist. And when the leading follicle is around 17, you will do a GnRH trigger. But instead of giving a daily GnRH trigger, you give a depot trigger. So depot trigger will also cause as an ovulation trigger. You do the retrieval, and the GnRH agonist depot that you are given will cover the gonadotoxic treatment later on, which will start immediately after the pickup, and it will also protect the ovary. So this is how the GnRH analog has been shown to protect the ovary. There are different ways in which it protects, and this is one of the important therapies which we give the patient when we are starting them on chemo or radiation therapy. This is a paper by Anna Viga's group where they had studied the patient over. I wanted to just show the Anna Viga group. She had studied 1,712 oncofertility cycles, and you can see that the oocyte survival rate after freezing and thawing these in nearly 80 thaw cycles was 81%, and clinical pregnancy rate was 41%. So fertility preservation is now available to all of us in a big way. If you look at the technique of fertility preservation, it is the oocyte freezing is the commonest technique, and we started this technique first time in India in 2007, and we have done huge amount of nearly 20,000 oocytes have been preserved over the last many years. And you normally use the DMSO ethylene glycol combination solution. You drop the oocytes into the ethylene glycol DMSO solution and expose them for 5 to 15 minutes in the solution. And once they are exposed and the cryoprotectant perfuses into the oocytes, there is the initial contraction of the oocytes followed by re-expansion. And after that re-expansion, you can then put it on a carrier system. This is a closed carrier that I'm demonstrating. Normally, we use an open carrier system, but if the patient is viral positive, such as HIV or HBsAg or HCV, then we use a closed system for preserving the oocyte. So once they are exposed for 15 minutes in the first solution of 7.5%, we then expose them to 40 seconds of the second solution of 15% weight by volume, and then put them on a carrier system in a very small droplet, and then dip them directly in liquid nitrogen, or you can put them, as you can see in this closed system, you put them in a carrier, and then we seal the carrier and then drop it into the liquid nitrogen. But in an open system, we directly drop it into the liquid nitrogen. We have done a lot of studies now, and the closed and the open system have nearly the similar results. There's not real difference in outcome. But the more important trick is the thawing procedure, where you must take the straw very much near the thawing media. So the distance between the two, that is the thawing, and is very short, and we quickly remove it and put it in the media. So if you take more time to remove it and put it in the media, the oocytes will get destroyed. You can see here beautifully the oocytes recover. Almost 95% recovery of oocytes is there in our group. You can see that between 2007 and 2020, we did 17,222 oocytes, and our recovery rates and pregnancy rates have been very good with frozen oocyte cycles. Another important thing which is very important in our group is we use spindle check technology. So before we freeze the oocyte, you can see here, there is this spindle you can see here. It's a fabulous technology which we have got, and you can actually see the spindle. So we do not freeze the oocyte unless the spindle is formed. And whenever we thaw the oocytes, we wait for the spindle to reform before we do micro injection on this thawed oocyte. This is a very important step for preserving the oocytes. And the second program that we have imported now and we have put in our is the artificial intelligence program, which is called, so we call it grading of eggs with AI toolkit. And in this, actually, you can take the photographs of the oocytes and export it to the server in Canada. and the server tells us whether this oocyte will give rise to a blastocyst in the future or not. So if suppose, especially for patients who come to us for elective fertility preservation, where we want to preserve adequate number of oocytes so that they have a good chance of pregnancy in the future, in those patients, we can say, okay, in the first cycle, you had 9 eggs, but only 5 of them can give rise to a blastocyst in the future. So you need to have one more cycle. It is a fabulous program which is incorporated. So these two combination of these two systems, the spindle check system and the artificial intelligence toolkit, which helps us to give a better outcome, especially in the patients who are undergoing oocyte freezing. What about return rate and pregnancy rate? There's a review which has shown that 10.3% of 200 fertility preservation patients returned to use their cryopreserved specimen, and of them 57.1% had a live birth. So the return rate is around 10%, and the safety is also quite good. Many studies have shown that those patients who undergo fertility preservation are as good or as safe as those patients who don't. What about ovarian tissue freezing? The ovarian tissue freezing is no longer experimental. HT guidelines of 2020 has allowed it for clinical application, especially the slow freezing technique, and it can be done also in pre-pubertal females as well, or when there's no window period that you need to preserve the ovarian tissue very quickly. So what we normally do, because we get patients from all over the city of Mumbai, so if there's an oncosurgeon, he will phone us. So we go, and when they're operating, we can just go and take out the ovary. We wash it with saline and preserve it in the flushing media and transport it in the ice to the main lab where the ovary is dissected, and you can see that the medulla is removed and only the cortical strips are kept. You can see this in the video here. So when the ovary comes to us, we first will clean it up, and then we bisect the ovary and remove the medulla. We just keep enough, only the cortex, the only 1 millimeter of cortex is kept. Everything else is shaved off because we want to have minimal tissue, and one small piece of each of these segments is sent for immunohistopathology, so that, and so we know that there is any malignancy, metastasis in that strip of the ovarian tissue. Once that the ovarian tissues pass through the vitrification systems or slow freezing system, then we can put them on the carrier system. You can see this is a carrier system, and then we dip them directly in liquid nitrogen and we preserve them for future use when you want to put them back. So this is put into the liquid nitrogen, and then they are covered and stored in the tissue. So now when you are putting the ovary back, there are two techniques. You can, when most of the time we do hemioophorectomy. So when we put the ovarian tissue back, we use the bed of the ovary which is no longer active. It is destroyed by chemo and radiation therapy. We use the bed and we implant the frozen thawed tissues on the bed and cover them in interseed so that they don't fall out. The other way is to create a peritoneal pocket, and you can actually put the tissues in the peritoneal pocket. You can see in this video which has been taken by Israeli group, because I have not yet I have done a lot of ovarian tissue freezing, but I have not retransplanted them back as yet. So this is an Israeli group, a professor, I forget his name, but he's a very famous group. And you can see that you can open do a mini laparotomy, and you can do railroading technique. So when you're thawing the ovary, this is a dead tissue, you do undermining, you do a tunneling technique, and once you tunnel it, then you can take the frozen thawed strip of tissue and you can pull it through. So you put it through and pull it under the ovarian cortex, and many of these patients have spontaneous pregnancies. There is spontaneous ovulation, and then you can pack the patient using a 6-0 proline to keep the ovarian tissue intact. So these are so if you look at the recent analysis, there was a latest study where in 2020, 200 live births have taken place following the preservation of the ovarian tissue prior to chemo radiation therapy. And a recent article by Dolman's group in 2021 has shown that the chance of pregnancy following ovarian tissue cryopreservation and ovarian tissue transplant, this was a review of 285 patients, was 25%. Natural pregnancy chances are better than IVF. Many of them naturally become pregnant if you use good microsurgical techniques. Pelvic radiation drastically decreases the chance of pregnancy. chemotherapy to achieve remission prior to ovarian tissue cryopreservation does not affect outcome. Dose and type of chemotherapy can influence outcome, and reimplantation and relapse risk is very low. As I told you, we do immunohistochemistry nowadays to see whether there is a metastasis risk. And recently, there are certain studies that are shown you can also do NGS to find out whether there is a risk of metastasis. You can also do what is known as artificial ovary. So you can create a matrix, and you can, once you thaw the tissue, and if you are scared of a risk of malignant cell being put back, you can actually dissect the primordial follicles, culture the primordial follicles in vitro, and seed the matrix and create an artificial ovary and retransplant that ovary back into the body. Or you can also use stem cells. There is a great work going on in Japan and China on reprogramming skin cells and creating oocytes out of skin cells in the future. So this was just a case dissection. Prior to the COVID, I had a phone call from one of my friends, colleagues. Their daughter, 18-year-old unmarried medical student, had Hodgkin's lymphoma. They phoned me and I said, you come down. The next day, they flew down to Mumbai, and I did a scan. She had a normal AMH and normal ovarian reserve, and there was a follicle of 16 millimeters. Had I started the stimulation immediately, this 16 millimeter follicle would have consumed all the gonadotropin. So what I did was gave her a GnRH trigger. I ruptured that follicle. After 2 days, I called her back. The follicle had ruptured, and then I started her on antagonist with gonadotropin stimulation and gave her a GnRH trigger. We got 17 oocytes which we have vitrified. So using the follicular phase, you can actually plan the stimulation, which is the random start stimulation, and can achieve pregnancy. This is the last slide where male fertility preservation is also a big thing now. Of course, the standard preservation is the semen cryopreservation, and you must know that many of the males after chemotherapy, they naturally conceive, but you should wait for 1 to 2 years because the malformation rates when they naturally conceive are higher if they conceive within 1 to 2 years of chemotherapy. You can also do testicular tissue cryopreservation for onco-TC. And there are 4 experimental techniques that are being now done for the prepubertal male. So the prepubertal male is a challenging for fertility preservation. Prepubertal female, you can do ovarian tissue cryopreservation. But prepubertal male, you still freeze the tissue because you can in the future use the testicular tissue by you can create sperm using cultures. You can do autografting, xenografting, you can do spermatogonial stem cell transplant, you can do sperm derivation from pluripotent stem cells. So all these are experimental techniques which will be available in the future, and hence if there's a prepubertal male, you must not say no to him. You must explain to him that at present we don't have a technique, but you should surely take the biopsy and preserve it, because future technologies will be available to use that preserved tissue and convert them into viable sperm. So the take-home message is fertility preservation is here to stay. It is applicable in numerous areas. One can postpone fertility for lifestyle reasons. Life definitely exists after cancer, and one should push this technique for young patients and even standard patients of cancer. The survival rates are now nearly 90%. And many of these patients, they survive the cancer and get married, and they want to have children with their own oocytes and sperm. And fertility insurance is like life insurance. And if you want to evolve a fertility clinic, there are a lot of various areas like communication skills. You need to tell people that this is available. A lot of your colleagues, now after talking to so many oncologists, so many gynecologists have started getting at least 1 or 2 patients every week now. So because of the awareness is not there, so the referral is not so much. Now my friends have started phoning me and saying, oh, there's a patient that just 2 days back I had a patient who was undergoing a one-time cystectomy. So they said, why, doctor, can you send your embryologist to collect the ovarian tissue and preserve it? So people have started understanding that this kind of technology is available, and there's a lot of integration that is necessary for. And I think the Bangladesh society should all get together, just like the Oncofertility Consortium has got together in Europe. You must all get together, and some 1 or 2 centers of excellence of fertility preservation should be started in Bangladesh, so that all other doctors can send their patients to those centers of excellence. I would like to thank you for a very patient hearing.
Thank you, sir. We're really enlightened, and thank you again for giving hope to especially to the cancer patients and working so intensively to help them. Thank you. Now, the second presenter, I would like to invite Professor Prakash Trivedi, who would be talking about the unknown facts of fibroids in the infertility and ART. Professor Prakash Trivedi is the consultant gynecologist, endocrinologist, HRT consultant, sonologist, and urogynecologist. He is the president ISAR of this year and was the president of FOXI in 2015. He is MD gold medalist from the Bombay University in 1983, and he receives ICOG Vidya Vibhushan Award and so many awards. Professor Prakash Trivedi, over to you, sir.
Thank you very much. I'll just share the screen.
Yes, sir.
I hope my slide is seen.
Yes, sir. We can see, sir.
Yeah. So I'm going to talk about many unknown facts. Before I forget, I invite all of you from 4th to 6th of March. The ISAR annual conference is there in Delhi. Obviously, everybody who is listening this talk will find there were so many things of fibroid all the greats don't know. And our love affair with fibroids is for ages, I think so. Dr. Nargis, Dr. Laila, and Dr. Maruf, everybody knows. The biggest issue about fibroid is that we all are gynecologists, say 50,000 between Bangladesh and India. And all of us have our own idea about what causes infertility, what doesn't cause infertility. And the fact of the matter is we know nothing about fibroid. So many of my consultants, many of my very good patients, they always tell, okay, sir, how come you people are big doctors when you don't know anything about fibroid? And this is the final reason for which this talk is designed, and this is a big research I'm doing. Fortunately, I'm appointed as the SIG secretary by AHGL for fibroid for the world, and will be chair in 2024. Now, this is a patient who came from Melbourne, the mecca of ART, wherein she was having 37 years age, AMH of 1.37, and she told she was having some bad tumor or maybe tuberculosis. Bilateral nephrostomy was done. So we went ahead. I have many great female assistants. So the moment I pulled this fibroid up, the person, the pelvis, she told, okay, sir, she's pouring urine. So we removed her 11 centimeter, 8 centimeter, 6 centimeter fibroid, and we did bilateral stenting because we were promised, though she didn't need it. Of course, we removed the nephrostomy wound. A few months back, they had called us that what was the scar, etc. So my son sent the film, and a cesarean was done with a spontaneous pregnancy. This is a patient from New Zealand, and she had a big fibroid, and they told this is not our cup of tea. That is not inferior vena cava, that's the ureter. And we went ahead. Of course, we have done 28,000 laparoscopic myomectomy. So no myomectomy, according to me, are really very difficult. And we excised this fibroid. I remember because this lady, you know, when I was taking around on the last day, of course, she was very comfortable, but I overheard that she liked vada pav and chicken biryani. Yeah, butter chicken or something. So I had told that when she comes for suture removal, you have to give it to her. So this we removed. She had one child. The ureter is normal. And at present, she is having a pregnancy. Again, it's a spontaneous pregnancy. So very, very often what I feel is we know nothing. There are no guidelines in the world which really gives you indications of when to do surgery for fibroid. All these cases which I'll show it to you, there were no classification mentions. This was, we were doing it over one of our IAG president's conference. They had a myomectomy in the morning, some difficulty, and they opened up. Smartly, he always keeps difficult case for me. So I went ahead, we started, because the mass was not detected actually as a fibroid, but it was detected as a variegated tumor, posterior and anterior. There was pin drop silence in the audience because they saw, okay, I'm not using a myoma screw or tenaculum. You can see the structure. Then we went ahead. And even anteriorly, this was the 58th or 59th case of angiolipoma reported in the world. And by the time I could ask for the film, this person, he says that every time when you come and do surgery at our place, she was having 12 years of infertility. In 3 months, the patient gets pregnant. So none of us know. And during my talk, I'm going to tell you so many facts that will shock most of the people. And there's a lot of big research which is going on with respect to fibroid. And it's not only submucous, 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 and submucous. So this, when we have the largest series of in-bag morcellation, 821 cases for which we got an award in Vancouver. And when we put this in a bag, you can feel either whether it's a dermoid, what tumor it is, nobody knows. But then the histopath report came to be angiolipoma. Which is a rare tumor, and she conceived within 3 months and was delivered by cesarean at the same place wherein I operated during the workshop. Again, what I'm trying to give an idea is, this is a tom-tom myomectomy case. Obviously, we know this doesn't come into fertility issue. Both the tubes are free. The removal of fibroid was, and the suturing was done in 10 minutes. And then the important thing came in, and that was when we put it into the bag. When we put it into the bag, we started morcellating this large fibroid, and you will see what happens. You find it is like a big animal's egg with a yolk tissue like inside. This tissue you could not remove with morcellation. So the fact of the matter is, when we don't know anything about fibroid, how do ART consultant and how do endoscopists make a decision, okay, this fibroid, there is no problem. And way back in 1994, in our book, which we had published also, and we had told that fibroid itself produces prolactin. So many such facts I'll be telling. So ultimately, this we had to remove through an ovum forceps because it was not possible to actually morcellate. So we are removing it with the ovum forceps. Everything was fine. She conceived on her own. Obviously, she was to conceive because tubes and all were normal. Again, if you see here, this is another case. All these are fertility cases. No world literature gives you any classification for such fibroids. From 14th May 2015, we remove all this in the bag. See the degenerative fluid which comes. There are a lot of facts I will be sharing with you. These videos I am showing because it gives you an idea that most difficult fibroids in the world are coming to Asia, because we don't have any ban on morcellation. And in bag, we have the largest series in the world. So people come from America, will come from Canada, will come from Gulf, will come from any places, There is no harm in doing an open surgery, but if you do an open surgery or even a naked morcellation in this situation, you're going to cause enough of peritoneal irritation, which may be not beneficial, at least for the fertility and for patient's normal health. This was a case done hardly 5 days back. And this was a teacher. She's unmarried, but she had a large fibroid in the cervix, and MRI had shown. And the moment I saw this, my son, who is also a laparoscopist and robotic surgeon, he told, okay, it looks like METS. I told, no, this is miliary peritoneal leiomyomatosis. And fortunately, I was lucky that the diagnosis also came. So she had such 60 or 100. This is next to the ureter. Now, my point is, what do we know about fibroid that we are so confident to tell, okay, this doesn't cause fertility problem. This causes fertility. This causes infertility. Only one criteria. Something touching the endometrium only causes. In endometriosis, what touches the endometrium? Nothing. In hydrosalpinx, what touches the endometrium? Nothing. So we send this. So these are interesting cases. My point is, after doing so many thousand myomectomies and having 42% pregnancy rate, a large number of them which were spontaneous or even by IVF or other means. So this is what I think so we have to understand. And we took almost 30 years, because I was always irritated in 1992, 93 when people used to tell me, how come you are such a big doctor? So we started working, and now we have 28,000 myomectomy, removal of fibroid done laparoscopically, either only myomectomy or big size uterus. I'll be highlighting you about 2-3 important aspects. Of course, fertility rate improved on removal of fibroid in bizarre situation. And many times I write, this patient doesn't need fibroid removal, doesn't cause fertility, doesn't cause menorrhagia. If you have any query, please contact on my mobile number. You see, at that time also we had written that fibroid itself has high prolactin and higher level of aromatase. It produces itself. This was St. Thomas in our assisted conception unit, wherein intramural fibroid of 5 centimeter, when we removed, the pregnancy rate improved by 12%, implantation rate improved. Eric Sare from America, donor oocyte myomectomy, why the hell it will increase pregnancy rate? But it had 50% pregnancy rate. That means the recipient who had a fibroid, when you just remove, which means it is not just submucosal. Fibroid does many things, which you will hear in my talk. Obviously, everybody knows that subserosal doesn't cause any problem. Submucous can decrease pregnancy rate by 70%, decrease implantation, doubles the abortion rate. Open or laparoscopy is your own choice. Mohammed Ezzati pointed out, regardless of the situation, location, it impairs implantation. Intramural fibroid, as I told you, SOGC and many other can affect the fertility outcome. This I've already covered. It has come in the journal. Fibroids more than 7 centimeter should be removed prior to IVF. We are not talking about subserosal fibroid because we all know it doesn't cause any problem. Sunkara has done one of the largest work, 6,087 IVF cycle. Non-cavity distorting fibroid decreased live birth rate by 21%, cumulative pregnancy rate by 15%. So according to me, when we don't know what is the cause of fibroid, and I will be going into that details of those surgery. This was our own data. We will not go into details of that. Only that we are the largest series in the world for in-bag morcellation. The largest number of fibroid removed. The only second one who was close to me was my friend late Dr. Rakesh Sinha. And AGL acknowledged our research in Vancouver and also appointed me into the SIG group. Of course, we had 42% pregnancy rate. This part is a small part. Now, this is the most interesting aspect. All of us know that fibroids are monoclonal tumor. Each fibroid has chromosomal problem. 40% will have, either they have deletion of chromosome 7, they can have trisomy. A friend from Singapore had found the type 3 fibroid increased pregnancy loss 3 times more. Now, the most important thing, the 3 biggest fact I'm going to tell, which in next 3 years will change the entire management of fibroid. Fibroid itself produces prolactin, and this prolactin is not pituitary source. It has no connection with the pituitary. So when before surgery, you may have a prolactin of 169, protein which is less. When you remove after surgery, the prolactin goes down to 19 and protein goes up. Prolactin is not only produced by fibroid, but placenta and uterine muscle. This is a fact which we had mentioned in 1994. The other important point is there are prolactin receptors on the uterine cell, endometrium. It does have stimulatory effect. So basically you have to remember that prolactin is the hormone, the genetics control the fibroid development, which I will come into in 2-3 minutes. But prolactin is the thing which is the tumorogenic factor. So basically there were studies wherein if you have a very raised prolactin, you will have luteal phase deficiency because progesterone and estrogen goes down. So this synthesis is very important. And this is what we have to remember. That this is one fact which we are declaring for almost 20 years. Now it is already published in many places. So basically you can have to suppress prolactin because it can be tumorogenic for pre-malignant and malignant lesion. So it's also seen in high-grade squamous carcinoma, cervical carcinoma, and I'm leaving the rectal carcinoma and GI carcinoma, where again prolactin is important. So all this is dependent on prolactin produced locally, not prolactin produced in the pituitary. So there were studies wherein they suppressed prolactin, and they found that there was a beneficial effect in reducing bleeding, pain, size, fertility, etc. The second important fact is fibroid itself has 3 times higher level of aromatase, which means the two products from the androstenedione or the testosterone base, you can get estrone. Estrone can be converted to estradiol, which is the functional estrogen. So you have localized. So if you are in the fibroid and 3 centimeters away, aromatase level is 3 times higher in the fibroid tissue. So this is what aromatase does. It increases production of estrogen. So you have already had genetic problem, then you already have raised prolactin, then you already also have raised aromatase. So androgens are catalyzed to estrogen, and then because of aromatase, they are converted into functioning estradiol. So these are the important factor. There are various studies which are done wherein aromatase inhibitors were given either in continuous form or in suppressed form, and they found that there was big relief in treatment of. Most of us feel, 80% feel, oh, this fibroids we don't have to touch. Laparoscopy is like a packet of sweet in the abdomen. They want to remove each and every fibroid. I don't remove 40% of fibroid because I know they don't need removal. So you have to have standardized criteria, and we have to stop. We have to understand that the sun rises in the east because there is more knowledge in the east. And we always follow what the West tells. Okay, don't do more selection. No, don't do this. Don't use tape. Don't do this, etc., etc. It's high time. Like people in India, people in Dhaka, people in anywhere in Asia, maybe in Pakistan, maybe in Sri Lanka, all of us can contribute. Singapore. So we have to understand there were 2 studies on aromatase inhibitor, Beirut study, Plum study, wherein they found that either you give continuous or intermittent, efficacy, rate of growth, and long-term symptoms were suppressed. So I have told you two important things I have told you. One is the prolactin, second is the aromatase, and now we come on to the genetic, which is the last part. All fibroids, each fibroid has different gene structure. And if you have 7q22, it may lead to lipoma. I have removed my wife's lipoma. I have removed my sister's lipoma laparoscopically. And I'm happy that my son removed my daughter-in-law's fibroid laparoscopically. Now in genes, you have to understand if you have MED12 gene mutation, which is there in 75%, then it leads to multiple small fibroid. Whereas if you have HMGA gene overexpression, you have a large single fibroid. So we now clearly know that genes control multiple fibroid or large single fibroid. And the other important factor is even the extracellular matrix. So simple hypoxia, menstruation, pregnancy, childbirth, it irritates the junctional zone. That is where the fibroid forms, and that's why the vascularity is less. So we have now clear idea that genes control multiple or single fibroid. Prolactin promotes growth. Aromatase inhibitor increases estrogen. So we have everything in front of us. And this is who is telling, this is a laparoscopic surgeon is telling, because I'm trying my level best to work on a formula or on a method which will reduce 70% of the surgeries in fibroid and our patients will be happy to have reduction in symptoms, reduction in all those problems. And you can study all these things properly. These are the two paths in genes. MED12, multiple fibroid, HMGA goes in excess, it will give you a solitary fibroid. So basically, in conclusion, I have taken 18 minutes, 30 seconds. This will take less than 1 minute. You have to remember that genes have a problem. Prolactin has to be suppressed. The gene network can be modified by gene therapy. You have to have MED12 or HMGA gene expression. We have to sit with the geneticist. We have to work on the aromatase inhibitor and all this, and then reducing the extracellular matrix. It may form the best non-surgical form of treatment. And why I love fibroids, because every time we get controversy, and that's why I do research. Why? So that I avoid surgeries for fibroid. And we are sure we'll find out again. Thank you very much for the patient.
Thank you, sir. Thank you for your presentation. And it is such evidence-based and elaborate that I'm sure that it is going to impact on our decision-making of treating fibroid patients with infertility and other cases. Thank you again, sir. Now I'm going to invite the third speaker of our session. Our third speaker is the renowned Professor Muralidhar V. Pai, and he will be talking on the hyperprolactinemia and infertility. Professor Muralidhar Pai is the Dean, Sikkim Manipal Institute of Medical Science, Sikkim. He is a professor and HUD of Manipal KMC, and he's the founder and current chairman of Karnataka College of OBGYN. And he is has 198 publications, and he has 30 years teaching experience, and he's an examiner for 30 years. Over to you, sir, Professor Muralidhar V. Pai.
Thank you, Dr. Nargis. I would like to thank at the outset Dr. Professor Chowdhury and Professor Maruf, who have invited me for this conference. As after a long gap, I'm visiting Bangladesh again. Also, I thank the chairpersons, Dr. Sahala and Sharia. I would like to now jump into the topic straight away. Okay. So you can see the slides and you can hear me.
Yes, yes.
Yes, sir.
So hyperprolactinemia is a very, very important aspect in the fertility of a woman as well as in men. I will be touching upon the definition, etiology, clinical presentation, diagnosis, evaluation, and management. As far the definition is concerned, in men and postmenopausal women, when it is more than 15 to 20 nanogram per ml or 15 to 20 microgram per liter, whatever way it is expressed, whereas in premenopausal women, when it is more than 30 nanogram per ml. The etiology, there are a whole lot of things that can give rise to hyperprolactinemia, including some of the things which Dr. Prakash Trivedi mentioned. Physiologically, even exercise, coitus, pregnancy, sleep, stress, food, basically proteins, can give rise to hyperprolactinemia. So one should be aware of that while interpreting the results. Pathologically, it can be divided into hypothalamic or pituitary stalk causes such as granulomas, infiltrations, irradiation, Rathke's cyst, craniopharyngiomas, and supracellular surgery. As far as pituitary causes, acromegaly, micro or macroprolactinomas or adenomas, paracellular mass, surgery in that area, trauma. As far as systemic diseases or causes, neurogenic chest, renal failure, cirrhosis, of liver, cranial radiation, epilepsy, PCOS, pseudocyesis can also give rise to hyperprolactinemia. Why we should know that? Because it is very important to pinpoint the cause of hyperprolactinemia. Otherwise, we'll be simply doing wrong things. Some of the pharmacological agents that we use also can give rise to hyperprolactinemia. Anesthetics, anticonvulsants, antidepressants, antihistamines, antihypertensives, cholinergic agonists, dopamine receptor blockers, dopamine synthesis inhibitors, COCs, antipsychotics, neuroleptics, catecholamine depletatory agents, opiates, opiate antagonists, neuropeptides, and whole lot of drugs. So a detailed history of all these things have to be taken before we start branding her as a case of hyperprolactinemia and treating her. What is the clinical presentation? This is very, very important. Clinical manifestations of hyperprolactinemia are relatively few and usually easy to recognize. This causes typical symptoms in premenopausal women and men, but not in postmenopausal women. That is because as such, in postmenopausal situation, the hypogonadism that an hyperprolactinemia can cause is already existing and the body is used to that. So they are not very obvious in postmenopausal women. In premenopausal women, however, it causes hypogonadism with symptoms that include infertility, oligomenorrhea, and amenorrhea, but this is only in 10 to 20% of the cases. The most notorious or famous galactorrhea is less often, in fact, only in 1/4 of the patients with hyperprolactinemia. Headache, that is basically due to a space-occupying lesion, maybe adenomas. Symptoms of hypogonadism correlate with magnitude of the hyperprolactinemia. What are the grades? The overt hyperprolactinemia is one when it is more than 100 nanogram per ml. There will be subnormal estradiol secretion and its consequences, including amenorrhea, hot flashes, and vaginal dryness. Moderate is one when it is between 50 to 100. It causes either amenorrhea or oligomenorrhea. Mild is the one when it is between 20 and 50. It may cause only insufficient progesterone secretion and therefore a short luteal phase of the menstrual cycle. Infertility, even in the absence of menstrual disorder. This is very, very important to understand. That's why in the investigation of infertility, estimation of prolactin is a must. Even mild hyperprolactinemia can give rise to problems of infertility. Bone density is another issue. Women with amenorrhea secondary to hyperprolactinemia have a lower spine and forearm bone mineral density compared with normal women or women with hyperprolactinemia and normal menses. This is again a cause of or due to hypogonadism, that is because of hyperprolactinemia. Restoration of menses following therapy results in an increase in bone density, although it may not return to normal. Adolescents, when compared with adults with prolactinomas, have lower bone density at the time of diagnosis and less important after 2 years of therapy. Galactorrhea, as I said, most premenopausal women who have hyperprolactinemia do not have galactorrhea. Only 1/4 will have. Many women who have galactorrhea have normal serum prolactin concentrations. This is another way of looking at it. Whereas in postmenopausal women, they are already hypogonadal and hyperprolactinemia does not change that situation, because postmenopausal women are also markedly hypoestrogenic. Galactorrhea is very, very rare. HPRL in these women is recognized only when lactotrope adenomas become so large as to cause headaches or impair vision, or is detected as an incidental finding in MRI for other reasons. In men, hyperprolactinemia also causes hypogonadotropic hypogonadism, which is manifested by decreased libido, impotence or erectile dysfunction, infertility, gynecomastia, and rarely galactorrhea in a short-term situation. Whereas loss of muscle mass, body hair, and osteoporosis as a long-term consequence. There is decreased testosterone secretion and low serum testosterone. How to diagnose? Of course, we already have understood this in the definition itself. In men and postmenopausal, anything more than 15 to 20, whereas in premenopausal, anything more than 30 nanograms. Can be performed at any time, since usual daily activities have little effect on prolactin secretion. Having said that, we must know concentration may increase slightly during sleep, strenuous exercise, emotional or physical stress, intense breast stimulation, and high protein meal. Hence, the test should be repeated, if at all, on a fasting mid-morning. What is mid-morning? 8:30 to 9 a.m. If you do very early in the morning, you may get unusually high prolactin levels, because, as I said, it is increased during sleep. And when you get up and immediately go for testing, it may be increased. Or if you had a high protein meal last night, it would be increased. What are the pitfalls? There is something called hook effect. The caution should be exercised in interpreting levels between 20 and 200 nanograms in the presence of macroadenoma, because there is a possible artifactually low values due to hook effect. It occurs when a very high serum prolactin, example 5000 nanogram, saturates both the capture and signal antibodies used in the immunoradiometric and other assays, preventing the binding of the two in a sandwich. The artifact can be avoided by repeating the assay using a 1:100 dilution of the serum. The other pitfall is the macroprolactin. It causes hyperprolactinemia through decreased prolactin clearance. Its native prolactin that is bound to IgG and is usually 150 to 170 kDa in size, compared with only 23 kDa of the monomeric prolactin. So not of clinical significance anyway, directly, but patients can be misdiagnosed and treated as ordinary hyperprolactinemia. Misdiagnosis can be avoided by asking the lab to pre-treat the serum with polyethynyl glycol to precipitate the macroprolactin before immunoassay. Such a simple thing can avoid misdiagnosis. Having understood this, now let's see how to evaluate once you diagnose hyperprolactinemia by the serum values. Evaluation includes, you have to repeat prolactin levels if the first one is increased. The next step is to determine the cause. Most patients with hyperprolactinemia have lactotroph adenomas. Therefore, the evaluation is aimed at exclusion of pharmacologic extrapituitary causes and neuroradiologic evaluation of hypothalamo-pituitary region. History is very important. Rule out pregnancy, which is a non-pathologic cause of hyperprolactinemia. Medications, as I've already given a big list, but most important ones are patient taking estrogen, neuroleptics, antidepressants, cimetidine, verapamil, methyl dopa. Ask the history of headache, visual symptoms, which will suggest space-occupying lesion in the brain, symptoms of hypothyroidism, they have a close connection always, and history of renal disease. maybe the lack of clearance. Physical examination includes the chiasmal syndrome, bitemporal field loss in the optometry. Looking for chest wall injury, because that can also give rise to hyperprolactinemia. Signs of hypothyroidism and hypogonadism. Lab and imaging include tests for hypothyroidism and renal insufficiency, MRI of the pituitary with contrast. If a mass lesion is found in sella turcica, secretion of other pituitary hormones should also be evaluated. Only a pituitary adenoma can cause hypersecretion of other pituitary hormones. This is very, very important. But any mass lesion in the area of sella can cause hyposecretion of one or more pituitary hormones. This is very, very important for us to understand. Hormones to be assessed: if a mass lesion is found in sella turcica, serum prolactin, of course, insulin-like growth factor 1, plasma ACTH, FSH and LH, TSH and free T4. All these should be assessed. MRI, if it is normal and no obvious cause of hyperprolactinemia is found, then you diagnose it as idiopathic hyperprolactinemia. It may be due to microadenomas sometimes that are too small to be seen on imaging, even though MRI can detect 2 to 3 millimeter size microadenomas. MRI in drug-induced hyperprolactinemia only if it is more than 100 nanogram per ml, as most drugs do not cause an elevation more than 100. Risperidone, which can cause an elevation up to 300 to 400, is the only drug which we should be very careful about. There are no stimulatory or suppressive endocrine tests that distinguish between causes of hyperprolactinemia, so no point in doing that. We must exercise caution in chronic kidney diseases due to decreased clearance of prolactin, which I have already mentioned. Serum concentrations can be elevated to as much as 10-fold normal in patients with end-stage kidney disease requiring dialysis. In such situations, in the absence of other pituitary hormone abnormalities or symptoms suggestive of pituitary tumor, example visual loss, typically need no further pituitary evaluation. We know that it is because of chronic kidney disease. There is something called ectopic prolactin. Secretion from an ectopic source is uncommon though, but has been reported from several types of tumors. Just now, Dr. Prakash Trivedi was telling the fibroids can secrete prolactins. Suspected when HPL hyperprolactinemia is not associated with a large cellular mass and is completely resistant to cabergoline. Management, of course, whenever it is drug-induced hyperprolactinemia, we have to discontinue the drugs for 3 days or substitute them with the alternative drug, followed by reassessment of serum prolactin. That will confirm the diagnosis. Discontinuation or substitution of an antipsychotic agent should not be undertaken without consulting the patient's physician, because sometimes hyperprolactinemia may not cause any harm to you, but stopping antipsychotic drugs may. MRI to differentiate between drug-induced hyperprolactinemia and symptomatic hyperprolactinemia due to a pituitary or hypothalamic mass should be done. No treatment is necessary in the asymptomatic patient with drug-induced hyperprolactinemia. As I said earlier, usually the values will not be more than 100. If the drug cannot be discontinued or substituted, and the patient has hypogonadal symptoms or low bone mass, then you may consider estrogen or testosterone therapy, because you cannot stop the drug. You cannot substitute a drug. Patient has symptom. So give estrogen and testosterone instead of trying to suppress prolactin. This is to be understood very clearly. But when you find a prolactinoma, the management is different. You have to use dopamine agonist therapy to lower prolactin levels, decrease the tumor size. This will also do the job, and restore gonadal function for patients harboring symptomatic prolactin secreting macroadenomas or microadenomas. Typically, we use nowadays cabergoline 0.125 to 1 milligram twice weekly for 12 to 24 months. It is preferred to other dopamine agonists because it has higher efficacy in normalizing prolactin levels as well as a higher frequency of pituitary tumor shrinkage. With 6 months of cabergoline in macroadenoma, menses were restored in 82% of the cases. Normalization of prolactin was seen in 81% of the cases. Significant shrinkage of tumor is seen in 92% of the cases. In men also, after 6 months of treatment, prolactin was normalized in 86%, nocturnal penile tumescence and sperm count and motility were restored. How do you follow? Periodic prolactin measurement starting 1 month after therapy to guide treatment intensification. Repeat MRI in 1 year or in 3 months in patients with macroprolactinomas. Visual field examinations in patients with macroadenomas at risk of impinging the optic chiasma. Assessment and management of comorbidities, for example, sex steroid dependent bone loss, persistent galacturia in the face of normalized prolactin levels, and pituitary trophic hormone reserve. This is a tough situation. Galacturia without hyperprolactinemia. Prolactin is often 46% normal in galacturia, as I said, even higher if menses are normal. No cause is documented. Often it represents persistent milk secretion following resolution of a previously elevated prolactin. Galacturia in the absence of hyperprolactinemia is not the result of any ongoing disease. So, how do you diagnose? Be sure that the breast secretion is clear or milky. Green or black fluid also usually represents milk. Bloody discharge needs proper evaluation to rule out malignancy. If milk is there, measure prolactin. If prolactin is elevated, cause should be sought. If prolactin is not elevated, no ongoing disease, no further test. What is the treatment? No treatment needed if there is no ongoing disease. For the unusual patient whose galacturia causes staining of the clothes, you may consider low-dose dopamine agonists such as 0.25 milligrams of cabergoline twice a week. This will reduce the prolactin concentration to below normal and reduce or eliminate the galacturia. Thank you very much for your patient listening.
Thank you, sir. Thank you for such a clear and elaborate presentation on hyperprolactinemia and infertility and its consequences. Dear audience, because of we are running behind time, I don't think that we can go for the question answer session, but because of the shortage of time, but I cannot resist myself to have a question, and I want to hear from Professor Rishikesh Pai that beside all the benefits of preservation of fertility, the elective and social fertility preservation is becoming popular, especially in the developed countries and more in the affluent societies. Professor Rishikesh Pai, can you hear me, sir?
Yeah.
I'm asking the question to you. For the I'm asking regarding the elective and social fertility preservation issue, and it is becoming popular, especially in the developing countries and in the affluent society. Don't you think that in the long run, its overuse may have adverse effect in social and biological norms, and there will be many young population who have very old age parents, and they will suffer from its consequences?
So no, basically I agree that the best way is to make them have children in the early life, so if there's a lot of studies that have come now that the fertility preservation before the age of 32 and after the age of 37 is not good. So 32 to 37 is the window. If you do it before 32, it is too early. Many of them will get married and anyway have kids naturally. So you're wasting the whole resource. And after 37, the egg number becomes very less and the egg quality becomes less. So 32 to 37 should be the window. And we must try to tell everyone to have children, get married before the age of 32. So it's important to, I agree, totally natural way is the best way. we must go back to our, in the olden days, we used to do everything in parallel. Na? We used to have children, we used to have a career. That's the best way. But unfortunately, nowadays, our children are not wanting to do that. They say, no, no, first we must get ourselves well established. Then only we will have it, our children. So these are things which our newer generation will adjust to it. Let's see how society will and the pre-existing conditions, how they evolve. We can't really, but 32 to 30. So I don't encourage people before 32 to come. I have never pushed the technique. Actually, I started the technique in 2000. I always felt guilty. I said, no, I will not push it. If someone wants to come and do it, fair enough. But I am not going to go out of my way and say you do preserve your fertility.
Thank you, sir.
Especially for non-cancer patients.
Thank you. That is what is the social preservation. Thank you, sir. Thank you, all the speakers. Now I am requesting our honorable national professor.
Can I make a small point?
Yes, sir.
I think so. We have our ISAR annual conference from 4th to 6th of March.
Yes, sir.
I'm seriously thinking that we can have a 45 minutes or an hour session on Bangladesh and Middle East society. So that all of you can come and we have a special session. This is my thought process, which is spontaneous on the spot.
Thank you, sir. Thank you for the opportunity. Thank you, sir.
I think it's a great suggestion by our president, Dr. Prakash Tiwari, and we would love all of you to be there. You are our brothers and sisters.
Yes, sir. Thank you, sir. Our pleasure, sir. We'll be. That will be. Now I request our honorable national professor, Professor Shala Khatun, madam. Madam, can you hear me? Madam, Shala, madam. Madam.
Madam has to unmute.
Madam, please unmute.
Madam, now I request our honorable national professor Shala Khatun,
yes,
to please make chairperson comment, and I request her to comment on Professor Rishikesh Pai.
Assalamu alaikum. Now it is good afternoon. Welcome all honored, learned speakers from abroad, the participants, ladies and gentlemen. I appreciate and really express my gratitude to the organizing committee of FSSB for inviting me and asking me to chair this very important session of fertility space, sparing surgery and related things. We are, old-aged people. In our time, there was no specific or specialty subject, so we deal with everything. Starting from the infertility treatment, fibroid, then fertility preserving surgery. And I'm lucky, I did one fertility preserving surgery in a very young, newly married woman, about 6 years. Now it's about 6 years. So she had one-sided ovarian cancer. I preserved, and after 3.5 years, she conceived. Now this child is about 3 years. But because of this pandemic, I don't know now how is she or her child, because in the family, there was a great catastrophe. I hope I will find out. But when it was 1 year old, the child, I saw completely all right. And the lady was also, there was no development of any problem. That is one thing. Now, thing is this. About the, fertility preserving, yes, definitely sparing surgery is now getting very, very important place in the world, and also country like Bangladesh and India, because we know very younger patients are now getting cancer, so many other things for which they need really preserve it, some type of preservation of their fertility. And one thing is this, we only know mainly about the breast and the fertility. Yes, after breast cancer, if it is completely cured, we know if it is completely cured, pregnancy does not cause any harm. But yes, if the breast cancer is during pregnancy or within 1 year of pregnancy, that is really very, very dangerous. Mortality is very high. I believe you people know better than me. This is one thing. And there are other types of ovarian cancer, like, germinal tumor, probably, what's the name is, germ cell tumor. These are the tumors we used to know from very beginning that yes, we can preserve the fertility and also they get pregnant. Now about the fibroids, this is really so many things I believe we learned from you. We know that yes, myomectomy, in our time, it was an open myomectomy for so many reasons, sometimes also for infertility. And now it is laparoscopic or hysteroscopic surgery. Definitely, I saw from your paper, it has increased the fertility rate and also pregnancy outcome. So I think this is something I learned from you, and also I believe the participant from Bangladesh also learned something from you. And it's a very, very, I should say, very challenging management of fertility in case of fibroids. Now, third speaker, Speaker Muralidhar B. Pai, hyperprolactinemia and infertility. Truly speaking, his, way of expressing is beautiful in the sense, it looks like I'm sitting in a lecture gallery, and my professor giving a lecture. Such a beautifully he has explained, and so simple words. And I came to know so many things about this thing which I really don't know. I don't have any knowledge to, knowledge to say something on this subject. But yes, we know hyperprolactinemia is a problem. We faced it from very beginning, but we didn't know so many things. Now it is 100%. You told us the causes, 100% causes is there. This is one very important thing. Normally we don't get the causes, we treat only. But here the causes are all well marked, definitely also the presentation and the treatment. I think this is enough for me to say this, auspicious gathering. I again convey my gratefulness to the Maruf Siddiqui and his team. He's working very hard for so many days to do it for a successful session of this one. And I believe it's really a very successful session, at least to me, and I believe also to my colleagues. Thank you very much.
Thank you, madam. Thank you again. We know that you have a very hectic time all day today. Still, you give us the time. We're so happy for that. Thank you again, madam. Now I request Professor Saria Tasnim, the chairperson, to make her chairperson remark on the topics. I think on all three speakers. Professor Saria Tasnim, madam.
Thank you, Dr. Nargis.
Thank
you. Assalamu alaikum. A very good afternoon to all the distinguished speakers and the participants. And it's my privilege to be one of the chairperson with my most beloved professor, National Professor Shaila Khatun, madam. Madam is very elaborately, she has highlighted what topics has been discussed. We had three very informative, excellent presentations during this session. The first presenter, Professor Rishikesh Paul, he talked about the fertility preservation, which is a very new concept and the time demanding topics nowadays. And he has gone through the ethical issues and other points related to that. And the second presentation was on the fibroid and the infertility. And fibroid is a disease of mystery. There are so many things that has been explored out, but yet there are so many things that yet to be discovered. And he has very elaborately, very nicely described the different aspects of fibroid with the relation with the infertility and how it could be managed. And the last presentation was on the hyperprolactinemia, and it was actually, it was, what should I say? I mean, it was just not full with scientific information, but very, very interesting as well. And there are lots of new things that was discussed. I express my gratitude to the learned speakers, and thanks for the Fertility Society of Bangladesh for giving me the opportunity to be present in this session as a chairperson. Thanks to everybody. Thanks to my moderator and rapporteur also.
Thank you, madam. Thank you for your comment. Now I request Dr. Pushpita Sharmin to please conclude the session. Dr. Pushpita, over to you.
Again, very good afternoon. My heartiest thanks to all eminent speakers for their informative and excellent presentation, which enlighten us very much and puts various new thoughts to us. I would like to thank our respected chairpersons to be there. We are very much grateful to them, and they conduct the session very wonderfully. I would like to thank our all delegates and learned audience to presence and patience hearing. I would like to thank our moderator, Dr. Nargis Fatima, for conducting the session very wonderfully. And last of all, I would like to thank to the Renata Limited, who sponsored the session. And this is our end of the session. And I would like to thank and give my gratitude to all the persons behind the session. And this is the end of our session. Now we'll go for a commercial break. And after the lunch, we'll switch over to the next session. Thank you all. Thanks.
Thank you very much.
Sorry to interfere. Actually, after the commercial break, we will have a brief remark about the morning session of today from our Secretary General, Professor Parveen Fatima.
Okay.
Concluded first three sessions of our virtual conference on day one. So may I request our Secretary General, Professor Parveen Fatima, to please comment on these sessions. Madam, please. Apa unmute করে নেন।
I'm really happy. The sessions were wonderful, and the speakers and the chairpersons and the rapporteurs and the moderators did wonderful. And especially, I thank Professor T.H. Udisa, the president of this Fertility and Sterility Society of Bangladesh, who is a key person for organizing the 6th International Virtual Scientific Conference of Fertility and Sterility Society of Bangladesh. His lecture on unexplained infertility, which is really a very interesting topic. And because many of the unexplained actually are not unexplained, they can be, we can find out the explanation for their infertility. Infertility, as it is a big problem, especially because these couples are being neglected for a long time and they cannot speak. So this session was where Sir have described about the infertility aspects of unexplained was very good for all of us. So we must take care of the infertility. And the speakers of the second session regarding premature ovarian failure, it is actually a problem. It is a problem of our country also, and also in the middle income countries, because nutritional factors, environmental factors, and aging process, and the premature aging has all contributed to it. So this topic was also very well selected, and the talk by Professor Budi was very interesting, and he has told us many things. And at the same time, in that particular session, there was something about PCOS and AMH. One is that there is premature ovarian failure, and with PCOS, where we find that they are supposed to, I'm always happy if I find a PCO patient, because I feel that their fertility will be for a long time because they have a good source of ovums, but it is difficult to make them fertile also, because but there are some easy ways to check their BMI, to reduce their weight, and some of the few techniques that can help them, along with some of the medication and assessment of their fertility with AMH, as Professor Claire has told, that with weight reduction, the AMH also gives a better understanding and better answer for our patients. So, and the third topic was on clinical utility of AMH. Really, we cannot deny AMH to understand our prospect of our infertile patients. There are lots of new thoughts about it. There are controversies still, but we find it that it is actually giving us some idea, and at least who can wait a little bit. And when the patient comes to us, all the patients are not ready for proper treatment which is needed by them. So we can also tell them by assessing their potentiality whether they can wait a little or they can try for longer times. Not only age, as it has been mentioned that age 37 and above is a difficult age. But what we find, when it is from the beginning of 30 years, the chance of getting pregnant and having a safe pregnancy reduces. So that is also to be thought about. The third session was really what we need. That is also the fertility preservation, especially for the cancer patients, for the people who may go into premature labor, premature ovarian failure, and for patients who may have cancer. So for them, this is an option which we must all feel, not only gynecologists, all the people of all profession must know about something about the cryopreservations and fertility preservation. This is a much needed thing. Maruf, I'll be requesting that we, together with all the different aspects of medicine, surgery, and the different people, we can start a collaboration so that fertility preservation becomes a understanding subject for all, and we can help our patients before they lose their fertility. And there's nothing more to say about Prakash Trivedi. He has described fibroid in an excellent way, what we know and what we don't know. There are lots of new messages that has been described by him. I thank him for the detailed and especially Muraldhar, who has told about hyperprolactinemia. We must understand what is hyperprolactinemia. He has given a very good classifications, and that really disturbs the fertility. The understanding of all this will help us. I think everybody is being benefited by these 3 sessions, and I hope you will be with us for the next few sessions that we will be having. And with that, I thank you all for staying with us for the day. But I'm a little unhappy. I find that people are very much interested in infertility, and I feel so proud when I find that everybody wants to join a fertility program. But today's attendance, why I'm seeing it is less? Because it's a Friday. Anyway.
No, Appa, actually, the participants you are watching in the Zoom, we have only allowed restricted people in the Zoom. But others who have joined directly, there are a lot of participants. But we can calculate that after a session. Okay. Maybe within 1 hour, we'll be able to calculate it.
Because I'm always interested that we gynecologists and the patients also must know something about infertility. And I'll be very much interested to know who are the participants who are with us today, and hope we can convey them the message that infertility is treatable, infertility can be taken care, and that age is important factor. In proper time, we can help. So with that, I conclude the first 3 sessions. And as this is a virtual program, we cannot invite you for the lunch, but I hope by at 3, we will be starting our next session. So please join us at 3. Thank you all.
Thank you. We are going for the lunch and prayer break. Inshallah, we'll meet you again on 3 p.m. Thank you all.
Thank you.